A very good morning, good afternoon, and good evening to all across the borders. So, I'm Dr. Nidhi Singh, and on behalf of iHERA team, we always aim to take the sharing of knowledge across everybody all over India. And now we had have a great pleasure to collaborate and spread our wings beyond our borders to Middle East Fertility Society of Embryology, which under the guidance and the leadership of Dr. Fadi and many of his wonderful uh, 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 people around him have collaborated with us. And today I welcome all of you here for this wonderful series of webinar. And I would like to introduce our founders and co-founders of iHERA. Can I have the CVs, please? So the conveys of the day are Dr. Fadi. Dr. Fadi has served as a scientific manager and lead clinical embryologist in Sidra Medical and Research Center. He's a ESHA certified embryologist having more than a decade of experience. Sir is also the chair of Embryology Special Interest Group of the Middle East Fertility Society and also the associate editor of Journal of Translation Medicine and Middle East Fertility Society Journal. Welcome, sir.
Thank you.
Dr. Ved Prakash, our very own, the founder of iHERA. Sir is a senior consultant clinical embryologist and the scientific director, Sperm Life Advanced Embryology at Delhi. Sir has been the regional head of the NOVA South End for quite a long time. He has been lab director of South End Fertility in Delhi. He's the past president of ACE. He has been a member of Virtual Education Committee, a faculty of fellowship in ART in Amethi, has diploma in clinical embryology faculty, and also visiting faculty at many centers. Welcome, sir.
Thank you. Thank you, Nidhi.
Dr. Sanjay Shukla, sir, he's a senior consultant clinical embryologist. Sir is an adjunct professor of clinical embryology in the Department of Medicine Science, Mahatma Gandhi University, and Medical Sciences Technology, Jaipur. Sir has been working again for a long decade in this field of embryology. He's a past president of ACE India, chairman of academic wing ACE, and also the editorial advisor and former editor of ACE newsletter. Welcome, sir. Now I welcome our second co-founder, that is Dr. Charudha Joshi, sir. He is the chairman currently Embryology SR. He is experienced more than 20 decades. Sir is a doctorate in life science. Sir is a medical director of Genes India ART Bank Indore, lab director in IVF unit RD Gardi Medical College Ujjain. He's a consultant embryologist and the past president of ACE Embryology. Welcome, sir.
Thank you.
I would invite Dr. Fadi to please say a few words of wisdom to all of us today.
Thank you, everyone. So first, I want to thank the iHERA, our colleagues from India, for this fruitful collaboration, which will be like a start in 2025, and I believe it will continue to support embryologists in our area in India and around the world. And secondly, I really appreciate and gonna thank our prestigious speakers who gonna present their recent research regarding like a topic which is like stirring now the scientific community, which is like the rapid movement in IVF labs. So it's a pleasure for seeing everyone, all our colleagues and our faculty in this event, and we're going to spend the next several hours getting insights into new innovations, new technologies, and also discussions which will be beneficial for your practice. Thank you.
So may I ask Dr. Ved sir to please again give some voice to our people here?
Thank you, Nidhi. And I would like to welcome all of you on behalf of iHERA and of course MEFS. This is a very good collaboration. You know that we have planned in a very last month. We just sit down and we just think about that. Why not to share the knowledge in between all the peoples around the globe? And this is now happening. It is coming in real. And I hope this collaboration will continue with this, and we share the knowledge amongst all the embryologists coming up, junior, senior, everybody. And we have very eminent speakers today. They are from US, European country, Qatar, and so many other countries. And we all are here to share the knowledge with all of you. Thank you so much once again. Thank you. Over to Nidhi. Nidhi, are you there? Okay, Himanshu, can we start with first lecture? Please share that CV. Move on. Yes. So our first lecture with by Dr. Nekati Fendikali. He is the IVF Laboratory Director at some hospital, Brussels, Belgium. Dr. Nekati hold a BS and MSc in molecular biology and genetic and a PhD in bioengineering, specialized in cell and tissue cryopreservation. And his career in ART began in 2000. He has since served as both laboratory director and scientific director at several esteemed private and hospital-based ART clinics. Currently, he is IVF laboratory director at some hospital in Brussels, Belgium. He has authored over 100 publications in internationally peer-reviewed journal, conference proceedings, and books. He is an SRA certified senior clinical embryologist, and he is an active member of several national and international scientific societies, including the American Society for Reproductive Medicines, ASHRAE, and he is a past president and current board member of the Turkish Clinical Embryology Society and the Turkish Society of Fertility Preservation. Over to Dr. Fendikali. Yes, Dr. Nekati, you can start.
Okay. Sorry. I hope that you can hear me well.
Yeah.
Yes, you can share your screen, sir.
It's actually, I don't have any slides, so you can just, share my own presentation here.
Yeah, it's okay.
Yeah.
Okay, please go.
Okay,
And I have some echoes on my ear. No, it's okay. Okay. Dear friends and dear colleagues, many thanks for your nice introduction and invitation. I always, feel a pleasure to be with you and among my international colleagues. And also, it's been emphasized in the invitation that it's going to be a TED-like talk. So I didn't prepare any presentation, slides. So in the next 15 or 20 minutes, I'll try to kind of speak about mostly on the philosophical way of time and space issue in IVF lab. Can we do faster, or what we do now, it's the fastest way, so we can kind of have an idea. And I think after me, so we have some very prestigious and key presenters who will be explaining the more detail in the cryopreservation part. So again, it's going to be a TED-like talk. So I try to prepare a philosophical approach, or I'll start with the philosophical approach by saying mother nature versus father time. So the concept of mother nature and father time are in fact metaphorical personifications representing different aspects of life and the universe. And since the beginning of our civilization, these figures have deep cultural, mythological, philosophical, and scientific roots, symbolizing the forces of creation, fertility, and renewal, and the change, also an aging and inevitability from the father time perspective. And their representations differ across different civilizations, but consistently reflect fundamental human understanding of nature and the time. So Mother Nature represents, as we all expect, the natural world, plants, animals, weather, the environment, the ecosystems, and the forces of nature, which also symbolizes growth, fertility, and balance in the environment. While the Father time represents the passage of the time, the unescapable nature of aging, symbolizing the fleeting nature of life, change, decay, and unstoppable movement of time also. So in the lab, so I will explain you in a minute why we care about these two stuff in the lab. And there seems to be an eternal battle or competition between them. Mother Nature nurtures and creates life, while Father Time dictates its duration. Nature is abundant and cyclical, whereas the time is linear and finite. On the other hand, they work together in a balance. Life emerges, flourishes, and inevitably fades. And in the literature, philosophy, and culture, they often appear as opposing forces, but they are actually the two sides of the same reality. Today I would like to present you the Mother Nature and Father Time metaphor in the context of the balance between natural and biological processes and the role of time in human reproduction, as well as IVF laboratory-related procedures. And the concept of the Mother Nature in human reproduction, we know, that presents the woman's natural fertility potential, the quality of the gamete cells, and the body's ability to conceive. And in the context of infertility, advances in reproductive science allow medical workers, doctors, or embryologists to assist nature. But we know that egg quality, uterine receptivity, and overall reproductive conditions still play a crucial role, meaning that the Mother Nature sets the foundation. Likewise, the Father Time symbolizes the biological clock and the impact of age on fertility. As a woman ages, the number of and the quality of eggs progressively decline, also the quality, and due to the natural effects of time. Time also influences, as we all know, the sperm quality, embryo viability, and pregnancy success rates. And all the medical and laboratory interventions developed in the field of in IVF so far aim to correct or bypass these natural limitations. So what we do in clinics or in the lab, we try to imitate the Mother Nature, or let's say bypass certain limitations that's been set by the Mother Nature, such as age-related fertility decline or numerous other medical conditions which affect human reproduction and creates infertility. So we can definitely say that in IVF, timing is everything. HCG triggering, oocyte retrievals or pickup, fertilization, embryo development, as well as selection, and embryo transfer must all be precisely scheduled and as well as synchronized. So the cryopreservation, which we'll be listening beautiful talks after my presentation, can be done either by gamete or embryo freezing, is an exception. In fact, I'm sure that other speakers, again, in the session will present their own exciting information. But from my side, and from Mother Nature or Father Time perspective, cryopreservation can be considered as the only trick that we know to pose or beat Father Time, which is also in the Greek mythology called Kronos, the Titan of the time, and allowing fertility to be preserved for the future. So in the IVF laboratory, as embryologists, all we try to do is to create a balanced and collaborative pathway by trying to imitate Mother Nature while also trying to minimize the negative effects that could be created by the time. So in other words, embryologists serve as the bridge between Mother Nature's biological processes and Father Time's precise procedural constraints. While nature governs gamete quality, fertilization potential, and embryonic development, timing dictates the success rates, and every laboratory procedure from oocyte retrieval to implantation. So knowing that the nature sets very strict and timely steps for successful implantation, what is our current practice regarding procedural timings in the IVF laboratory? So I would like to point out first that according to the current literature, there seems to exist optimal timeframes for different lab-related procedures, and indicating that performing a procedure outside of its time frame or the so-called published time frames can negatively contribute to the laboratory as well as clinical outcomes. So before discussing how fast we can perform a procedure, we should briefly outline how early or earlier can we perform a procedure without significantly affecting the embryonic clock. Because we cannot currently change the embryonic clock, but let's see whether we can kind of optimize or modify with an earlier sets of time frames. So why? Because it's a well-known fact that only oocytes with complete nuclear and cytoplasmic maturation, as well as spermatozoa with healthy DNA integrity and high motility, are capable of creating successful fertilization and embryo development. So, and the preparation of gamete cells for successful fertilization should be considered the optimal time when the gamete selection with these criteria can be maximized. And according to the recent literature, what we can say that, so the oocyte pickup should be performed between the 34 and 36 hours post-HCG, since we know that the LH surge initiates oocyte maturation. Oocyte retrieval must occur within the precise window. If there is a delay, there may be a spontaneous ovulation, so everyone knows, or oocytes may overmature and undergo post-ovulatory aging, thereby reducing the developmental potential. And if it's too early, we can say that immature or GV or metaphase 1 oocytes yield will dominate, and thereby we may be having no or a very smaller number of mature oocytes for insemination. So the best practice should be to first monitor LH surge and estradiol levels to ensure that the retrieval is scheduled optimally. And for ICSI cases, oocytes maturation check and the sperm preparation better be performed, according to the recent literature, better be performed within 2 hours post-oocyte retrieval. And in this way, one can assure that correctly matured oocytes are available before ICSI, as well as the best motile sperm can be selected while maintaining its physiological conditions. While ICSI bypasses natural sperm selection, the DNA integrity, motility, and morphology still impact fertilization and embryo quality. So the use of novel or shortened sperm preparation protocols or methods that mimic natural capacitation while improving selection is the key. So in the meantime, we have to note that the prolonged sperm processing increases reactive oxygen species, which may harm also DNA integrity. So that is the sperm preparation should be optimized, as well as the optimized maturation check of the oocyte for the ICSI cases, optimized for minimal processing time to avoid ROS-induced DNA damage, while making sure that capacitation is also sufficient for insemination for ICSI. So ICSI is better to be also done within 2 to 4 hours after pickup. It is because fertilization success is highly dependent on, as we mentioned, the oocyte cytoplasmic maturation, which needs a brief post-retrieval maturation phase before intracytoplasmic sperm injection. So optimal time frames for fertilization and daily embryo assessments are also very well documented in the first and the revised consensus document of Istanbul consensus criteria. So I'm not going to go into detail. However, I have to mention that currently the easiest, from my perspective, easiest and fastest way to perform such interventions can be to use, if possible, time-lapse embryo culture systems with possibly AI-supported embryo selection tools. Apart from the current debates about the potential, but overrated contributions, I should say, their ability as research as well as supporting tools are still very important for us, which can fasten the embryo assessment steps. And besides, although we all know that embryos follow a predictable timeline, individual variations in terms of embryo development is inevitable. Furthermore, the genetic and epigenetic factors influence also embryo development as well as the blastulation rates, even in seemingly optimal conditions. So embryos can, in fact, undergo self-correction. This is the let's say the theme or topic that we recently kind of try to uncover. So embryos can have the ability, although to a limited extent, self-correct themselves. So some delayed embryos may also still reach the blastulation stage successfully. Not at the predicted time, but maybe later, but still they can end up with viable embryos. So time-lapse imaging allows embryologists to track embryos non-invasively, identifying optimal developmental patterns without disturbing embryo incubation conditions. So we all know. And being the topic of discussion today, besides this optimizing this procedural timeframes, the speed or the duration of the interventions in the IVF lab are also critical, thanks to our current gamete and embryo culture systems and embryo manipulations that should be performed outside the incubators can be protected from significant harm potentially to be caused by the disturbed in vitro environment to a certain extent. And however, performing the procedures faster by shortening the operational steps to minimize such potential effects from the environment is always something that as embryologists we seek, but not from the biological reasoning only, but also from the daily operational workload perspective. So, however, the possible benefits or negative changes that can be exerted on the intrinsic genetic and epigenetic profile of the embryo still largely unknown. So we have a lot to go in terms of this fastening the procedures or make everything quicker than is expected. But we have to see the outcome or that the outcome of each procedure and extensively analyzed by a certain laboratory or clinical outcomes. So can we manipulate faster in the IVF lab? So that's the question. Current literature also indicates that the answer to this question can partially be based on the number of, as well as the experience of the operators, meaning that how many experienced embryologists or biologists you have in your lab, the setting of the IVF laboratory, and the ability of the clinic or laboratory to personalize the outcome. So from my experience, the first step is to standardize each procedure and the outcome among the operators, and then to seek the alternative or shorter options with comparative and well-designed studies. Performing ICSI faster can give us good fertilization, but the ultimate outcome should be the number of utilizable embryos that could be used to improve cumulative pregnancies or deliveries. So in this way, besides cryopreservation, I can say that potentially, if we want to beat the father time, except cryopreservation, also we can beat him by decreasing the time to achieve pregnancy. So splitting the manipulation of the, let's say, oocytes and embryos on the same cohort by different operators can potentially minimize the total time of the operation and allow us to perform faster. However, as I just mentioned, this option comes with its own material or disposable cost, for example, and may not be suitable for the labs having a limited number of equipment, disposable or the stuff. And from another perspective, in order to perform faster also, we know that some operators prefer to manipulate multiple oocytes or embryos in the same dish or a drop. While such an approach can shorten the total time of the operation, so we can do things faster, it can also bring its own safety risks, and that we can all imagine. And on the other hand, shortening the time between the embryo biopsy and subsequent cryopreservation has recently been documented to improve the laboratory and clinical outcomes in PGD cases, indicating that there's still room for improvement for us to increase the procedural speed in the laboratory for some operations or manipulations. And standardization and manipulation of the same cohort by different operators can potentially minimize the total time of the operation and allow us to perform faster. However, this option also comes from its own cost, as I mentioned. So standardization and or automation can also be another important step to create faster operational timings in the IVF lab. But knowing that not all gamete cells and embryos have the same durability and sensitivity in the environment or the manipulation, for relatively invasive manipulations especially, such a robust approach may also create unexpected damage or developmental loss, such as the damaged eggs during denudation or after ICSI. That is also very important for patients having a very limited number of available reproductive cells and embryos. And in the end, my takeaway messages from an embryologist point of view would be that the biology or the mother nature sets the constraints, but procedural precision, which is father nature time, determines the outcomes. An embryologist must synchronize lab protocols with each patient's unique reproductive timeline as far as possible or as much as possible. An advancement in terms of like novel procedures, automation, or shortened protocols always come with their benefits and as well as its costs or their costs. And implementation of these novelties in the lab and clinical setting in order to improve the outcome should always follow extensive, transparent, well-documented, and comparative studies. And by aligning lab protocols with natural embryonic kinetics or morphokinetics, together with faster interventions with documented safety studies, I believe that ART professionals, embryologists like us, can ensure science complements the nature with maximization of success in the treatments. So as embryologists, we should monitor each timeline starting from HCG injections or let's say triggering to avoid any unexpected premature or over-maturity for the oocytes and perform the other operations like denudation, ICSI, freezing, embryo biopsy, according to the windows that has been available by the literature. And if possible, we use time-lapse imaging to track developmental kinetics. And of course, we should always seek to find a faster way of performing an operation, but always take the physiological, technical, and safety aspects into account. And do not forget that such approaches always come with their own risks and costs. Thank you very much.
Thank you so much, sir. Sanjay, sir, are you there, sir?
Yeah, Dr. Sanjay is there. And excellent presentation, Dr. Nakati. It was wonderful, actually. And as rightly you already said that Mother Nature has some timelines and you have to
Yeah.
follow all these things. And in father's timeline, definitely you can uh, change something like that. But it is always, when you start this kind of thing, speed is good. And as we've seen in vitrification, now different protocols are coming up with ultra fast protocol and everything, and they are giving very good result. But in other hand, on other procedure, kind of, that doing ICSI and pickup timing, scanning timing, donating timing, uh, it is very difficult to change that timing because you have to match all the time. I don't
Mhm.
know how it will be possible in future, but definitely it is wonderful talk. And Dr. Shukla, I think he is going to ask you something. He's ready with some.
Not just exactly asking, but just a few comments. Like, of course, as you mentioned, and as Dr. Ved also mentioned, uh, as a biologist, our motto or our aim is to mimic what
Yeah.
nature offers. Uh, but I also believe that what we know is just the tip of an iceberg. So sometimes, maybe 2 decades ago, what we were doing in our laboratories when we stepped in was totally different than what we are observing these days. So it is always, a progressing nature of our learning. So as we unveil the mystery of science, we learn more and more, and then we adopt accordingly. Of course, nature has its own course of time. We have to respect that. But at the same time, we can refine our reflexes, we can refine our approach to, uh, you know, fine tune the day-to-day working that we do, so as to adopt newer things that are coming up, and of course saving the core of the mother nature. So it's a very fine balance between the two. But I mean, I'm very open to adopt anything which
Yeah.
offers any advantage if we can offer to our patients. So all in all, very, and I mean, beautifully explained philosophy of
Mhm.
biology. Thank you, Nikati.
Yeah.
Thank you, Nikita. So it's always an honor to listen to you. And I'll bring forward, can I introduce our next moderator and the speaker of the day?
And next,
I invite Dr. Fadi, sir. So if you could introduce our next speaker. Thank you, Nikita,
already,
sir. Thank you, Ved, sir. Thank you, Sanjay, sir.
thank you.
Shim, can we have the CV, please?
It is a great honor for me to present my colleague and my dear friend, Dr. Nagam Younes. So, Dr. Nagam is an associate IVF lab director at Ovation Fertility in the US. She has a PhD degree in reproductive physiology, focusing on fertility preservation of pediatric males from University of Jordan and University of Pittsburgh in the US. She's one of the earliest certified senior embryologists from ISHRE and from CFAS, with more than 25 years of experience in the IVF field. She's a founder of Ovatrain Academy for IVF training in Jordan, the first accredited IVF training center in the Middle East. She's a Secretary General of the Jordanian Society for Fertility and Genetics. She also peer-reviewed and co-authored many publications in the field, and also she's part of the Middle East Fertility Society Embryology Group Executive Committee. So, Dr. Nagam, the floor is yours to show us your findings and your research regarding the fast movement in the lab.
Thank you, Paddy. It's really a pleasure to be with you all here. And of course, I would like to thank the organizing committee from MEFS and iHERA for this kind invitation. It's truly an honor to present today alongside some of my colleagues and friends who are considered icons in the IVF field. I know it's a freestyle, it's dead style, but I have like technical data to present, so I would like to share some slides if you don't mind. Can I go ahead and share, Fadi?
Yes, ma'am. Yes,
Yeah,
ma'am.
yeah.
Okay. All right. So, okay. Do you see my screen?
Yes,
Yes,
ma'am.
we can see. Yes.
Perfect. So today I will be talking about how to enhance your lab efficiency with ultra-rapid warming of cleavage stage embryos. I will go over the history of the human embryo cryopreservation briefly um, to see how and appreciate the advancement that we reach at this stage of history. So the first report of live birth following the transfer of a cryopreserved thawed embryo was announced in Australia by Transon and Moore in 1983 using the slow freezing procedure. And I'm pretty sure that many of us use this technique for a long time. And we know that that technique was kind of time consuming and exert kind of stress on the schedule of the lab. Then the vitrification technique was introduced to the IVF field in late 1990s in Japan and Australia. And now most of the IVF labs, if not all, are using this technique for oocytes and embryo freezing. As we all know, a couple of years ago, the IVF world started discussing and implementing the ultra-rapid warming of blastocyst stage embryos using a 1-minute thaw instead of the standard warming protocol of multi-steps that takes 13 minutes. The results of this innovative technology showed that this technique is fast, safe, and even more efficient than the standard warming protocol in terms of higher ongoing pregnancy rate and lower miscarriage rate. These results were published in 2024 by my colleague and friend, Dr. Jürgen Lieberman, and his team at the Fertility Center of Illinois, which is also part of our nation-wide U.S. fertility network. Here, where ultra-rapid warming started to be a game changer in the lab. And instead of 13 minutes, now we start to talk about a one-step of 1-minute process. It is fast, efficient, and has the potential to improve the lab operations without compromising embryo quality. This is very important nowadays, especially with most IVF labs switching to freeze-all or VGT cycles. And this is something that grabbed my attention to try the same technique with the cryopreserved cleavage stage embryos that we have in our lab for a long time and were cryopreserved either by using vitrification technique or slow freezing protocol. So the results of our study were presented for the first time at the American Society for Reproductive Medicine, ASRM, meeting in Denver, Colorado in October 2024 last year. The objective of our study was to evaluate the lab outcomes as a first step, including survival, viability, and blastocyst formation rate after ultra-rapid warming of cryopreserved cleavage stage embryos that were originally cryopreserved, as I said, using either slow freeze or vitrification technique, and compare it to the standard warming protocol. So our study design includes two testing groups. Of day 2, cleavage stage embryos that were donated to research. The embryos from the first group were originally cryopreserved using the slow freeze technique, while the embryos in the second test group were originally freeze using vitrification technique. The embryos in both test groups were thawed using the ultra-rapid warming protocol by placing the embryos in the thawing solution, PS, at 37 degrees for 1 minute, using pet kit worm and eggs from Irvine Scientific. Those embryos then were moved to 10% CSCM and X culture media to be evaluated for survival rate on day 2, viability rate on day 3, and blastocyst formation rate on day 5 and 6. On the other hand, the embryos in the control group were thawed using the standard warming protocol by placing the embryos in the TS at 37 degrees for 1 minute, then moving them to 3 drops of DS and WS for 4 minutes each at room temperature. Then the embryos were also moved to the percent CSCM and X culture media to be evaluated for survival rate on day 2, viability rate on day 3, and blastocyst formation rate on day 5 and 6. So the main question here was, does speed compromise success? That's what we will see in the next slide. So the results in this table showed that the total number of embryos survived in post-test groups after ultra-rapid warming divided by the total number of embryos born, showing 90% survival rate in the first test group and 98% in the second test group. And that was compared to the survival rate in each control group that were thawed by using the standard warming protocol. The survival rate in both control groups showed 100%. Then we calculated the viability rate by dividing the total number of embryos that continue to divide on day 3 by the total number of warmed embryos, and we found that the viability rate was 100% in each test group compared to 72% viability rate in the first control group and 77% in the second control. And finally, we calculated the blastocyst formation rate by dividing the total number of blastocysts on day 5 and 6 by the total number of warmed embryos, and we have reported 52% blastocyst formation rate in the first test group and 58% in the second test group, compared to only 28% blastocyst formation rate in the first control group and 51% in the second control group. If we look at the results in this bar graph, we will see that we didn't see any difference in the survival rate between both test groups and their controls. But if we look at the first test group, which is the cleaved slow frozen, we will see that the viability rate in this test group was higher than the control group, but this difference was not significant. However, the blastocyst formation rate was significantly higher in this test group compared to the control group. In the other test group, or the cleaved vitrified group, we found that the viability rate was significantly higher in the test group compared to the control group, but there was no significant difference in the blastocyst formation rate between the first test group and its control. So the conclusion from this study, for our knowledge, this is the first preliminary study to report the safety and efficiency of ultra-rapid warming protocol of a human cryopreserved cleavage stage embryos. We haven't seen any difference in the survival rate between the ultra-rapid warming and the standard warming protocol in cryopreserved cleavage stage embryos. However, viability and blastocyst formation rates were significantly higher in the vitrified group and slow freezing group using ultra-rapid warming, protocol compared to the control group using the standard one, respectively. So these findings confirm that this novel protocol is feasible and efficient with embryos preserved using slow freezing or vitrification technique. And this is very important because there is no need for slow thawing or brand matching thaw protocol anymore. It significantly enhances lab productivity and efficiency while ensuring high-quality lab KPIs. However, clinical outcomes need to be investigated before this next-generation technology is ready to go universal with cleavage stage embryos. We are aware of some limitations that we have in this study, like the small size, sample size in the study groups, and we are still lacking the clinical outcome validation. So for future directions, we are working on evaluating the clinical outcomes, including beta-HCG pregnancy, implantation rate, and clinical pregnancy rate. We are also planning to investigate the euploidy rate after pre-implantation genetic testing. And there is a good opportunity to validate this technique also with different thawing media containing different concentrations of osmolytes. The take-home message: a faster IVF lab means we speed up the lab workflow, allowing more cases per day. And that was really very important to my team in the lab. Reduces the stress on the embryologist. And it always has potential to improve patient outcomes with faster procedures. These were the references that helped me in this study. And I can see here one of the references for Dr. Jürgen Lieberman, and Dr. Najati also has a good publication about successful application of single warming protocol for embryos cryopreserved by either slow freeze or vitrification technique. At the end, I would like to give a big shout out to my team at Ovation Fertility Grand Rapids in Michigan, United States, for their hard work and dedication to research. And thank you all for your listening.
Thank you, Nagam, for this insightful presentation. So I have like a few questions, and if others can join me, we have 10 minutes for questions. In your study, so are there any specific morphological characteristics or grading criteria to predict better outcome in this context? So have you only froze the embryos depending on the good quality embryos, the cleavage stage?
Okay, so now the trend in our lab is to go for blastocyst stage freezing. We have strict criteria related to the freezing system and embryo selection, either for VGT or for cryopreservation. So we don't freeze any purpur or CC embryos. But for our cleavage stage, which is, we really try to minimize doing that. Sometimes some patients, they come back with a good experience with the cleavage stage of pregnancy, ask for freezing their embryos on day 3. But we have also criteria for that. We don't go less than A, B. So we only freeze A and B. But as I said, we try our best to minimize that, and that happens very occasional in our lab. So we focus more on blastocyst stage embryos. And those embryos, we get the advantage of having them from the old days. That why we have like a bunch of embryos related to research, because they were even frozen on day 2. They were not frozen in day 3. And that give us a good space to evaluate viability, as I said, with the continued division on day 3 and blastocyst rate. So we don't prefer to freeze cleavage stage embryos
Another
unless there is
question,
an
which is,
indication for that. Yeah.
I know it's not like the gold standard to do a PGT on cleavage stage embryo, but there are some areas around the world they are still performing biopsy day 3, which is not the gold standard. Have you any experience, any validation data for breached zona for biopsied embryos on day 3 and sewing in this protocol?
Okay. So the system in our lab that we don't do day 3 biopsy. We only do day 5, day 6, or day 7. Okay. So what we do with those embryos that we saw them on day 2, if they were frozen on day 2, or day 3, if they were frozen on day 3, and we keep them in extended culture to day 5, day 6, or day 7, and then we biopsy whatever reached last stage. So, of course, I have experience with day 3 cleavage stage biopsy from the old days, but we don't do that anymore in our lab. It's only the blastocyst stage biopsy.
There's from in the Q&A in the chat, we have one from the audience asking if embryos were frozen by standard like vitrification protocol. Is it possible to thaw it by ultra rapid thawing technique? So
Yeah, very good question. This is the main point of our study, is to accelerate the procedure. I'm pretty sure that most of us, if not all, we were very concerned sometimes about the embryos coming to us from other clinics, what kind of media they use, what technique they use. We need to match the brand, we need to match the technique. But with our study, now we start to have a universal warming protocol in our lab, whether they were frozen by slow freezing, whether they were frozen by vitrification. We do the ultra rapid warming with 1 minute thaw. We are not concerned anymore about the brand or the type of media they used at that time. We receive, of course, many embryos from other clinics, from other places, and that was creating in the old days stress on the lab to make sure that we have this media in the lab before the thaw, that we are aware of their thawing protocol. And now with this universal protocol, now this stress is almost eliminated in our lab, and our embryologists feel so relaxed with their practice during the thaw procedure. And our result is showing that there is no difference between what we used to do and what we are doing right now.
So, Nagam, as you mentioned that whatever it is procedure, like protocol, like slow freezing or ultra vitrification freezing, vitrification method.
Yeah.
Did you find any difference in between, the slow freezing embryo after thawing or in vitrification freezing, thawing procedure? Slow freezing embryo, slow freezing embryo, vitrification embryo, when you thawed by universal protocol, warming protocol, did you find any difference between them
with the ultra rapid
in context of blastocyst formation?
Yeah, with the ultra rapid warming, right?
Yeah.
As I said in the study, that we found that the blastocyst formation rate was higher in the slow freezing embryos, okay, when we use the ultra rapid. And also it showed the same thing in the vitrified embryos, but it wasn't that significant. However, the viability in both groups were higher, and in the vitrified group, it showed significant higher. So survival rate was not different. Viability and blastocyst formation rate were higher in both testing groups, the slow frozen embryos and the vitrified embryos, when we use the ultra rapid warming, than the standard one that we used to use. So when we used to have the slow frozen embryos, we used to do the slow thawing. And now with this protocol, it proved that there is no difference. It wasn't even better.
Thank you.
Can I comment here?
Yes.
Please, sir.
So I used to, I started vitrification in something around 2006. And before that, the embryos were frozen conventionally with the slow freezing protocols. But then once I started and I shifted to vitrification, and I had my own, experiments with preparing in-house media and some in-house devices also. We know that before 2000 or in the early 2000, the embryos which were frozen with slow protocols, we did not have that, standard or that kind of media formulations and standard things. So embryos which were frozen in those times, when I tried to form with the universal thawing procedures, they did well, but then the outcome was not that good as we were vitrifying the embryos and warming them. So it was my observational study. And as you mentioned in your talk, so like I had a privilege to interact with Yogan when he shared his data in 2022. So um, I had a little experience with some, accidental uh, embryo transfers when I had very little time, and so we did those things. So encouraged with his, you know, experiments and his words, so I started doing this thing. Of course, first with the blastocyst, but in one of my clinics, they were still practicing day 3 embryo transfers. So I also tried with the cleavage stage embryos. And of course, I do not have the data at hand to show. I do have my data, which I presented in last year Fusion conference. If I am allowed, can I share this thing?
Please share.
Can you see it? Is it visible?
Yes, sir.
Yes, yes.
Yeah.
Okay, so it was basically from the blastocyst transfers, but I also have the experience with the cleavage stage transfers, mostly frozen on day 2 or day 3 and transferred on day 3. So we did not wait until the blastocysts, but we observed the similar pregnancy rates, if not less than the conventional vitrification thawing procedures. So even in this case, this data is from one of the centers, and we had performed 205 transfers, and that resulted in something 53% pregnancies. And of those, we had 79 live births, and there was no significant event during the pregnancy or the outcome with respect to the abnormalities in the kids. So I'm pretty happy with those, and I assume if I mine my data from the cleavage stage, it will be the same as we had with the conventional vitrification and warmings.
Thank you,
Great.
Dr.
Thank you.
Nagham. Dr. Sanjay, we can also further discuss your experience at the panel session at the end
Sure.
of the program.
Sure.
Yeah, will be also from different parts, different experience. Dr. Nagham, thank you for this insightful presentation. Now we're gonna move on.
Thank you, Dr.
our-
Fadi and Dr. Nagam. And I invite the next moderator, Dr. Charulata Joshi, sir. Can you have the CV for the next speaker, please?
Yeah, thank you, Nidhi. And it is again my pleasure to invite Dr. Georgian Lieberman. And he is a certified as high complexity clinical laboratory director through the American Board of Bioanalysis. Dr. Lieberman has been working in this field of IVF since 1995. And he is the director of services, laboratory services at Chicago-based fertility centers in Illinois River North Center for Reproductive Health, a proud partner of US Fertility Network, has received doctoral degree from Technical University Munich in Bavaria, Germany in 1995, and his postdoctoral thesis in 2004 qualified him as university lecturer in experimental reproductive medicine at Bavarian University, Wittenberg, Germany. Dr. Lieberman has been frequently invited to present at various national and international meetings and has authored various papers in different books, abstracts, and journals. He co-authored a book with Dr. Michael Tucker titled Vitrification in Human-Assisted Reproduction. And there are so many things to his credit. It's an indefinite time it will require if we go each and every achievement of Dr. Lieberman to describe. So basically, he is going to talk today. We have listened till now vitrification, and this vitrification has changed the entire scene in the field of infertility, and it's a very common procedure. But we also know that there is an effect of this cryoprotectant which are using on the embryo, on the cell, its exposure time, and there may be carcinogenic effect also. So let's listen from Dr. Lieberman about this phenomena and effects of cryoprotectants on embryos. So over to you, Dr. Lieberman.
Oh, thank you very much. Let me share my screen. Thank you for the kind introduction. I very much appreciate to be here and being invited from your very prestigious societies, both of you. Let me share my screen. Okay, everyone is okay seeing it?
Yes, sir, please.
Okay, so as you see, my title is a little bit odd. I bring Dr. Oppenheimer in my talk. Most of you may be familiar with Dr. Oppenheimer, if not, at least after the movie. And what I mean with that is pretty much how we create with what I will present to you chain reaction. It just doesn't affect the embryo falling in a very short time. It affects a lot of other steps coming with the falling of these embryos. Why we actually are here and talking about faster, we actually talking about a dogma in cryobiology, right? A dogma in cryobiology is that you have to freeze and warm in stepwise procedure, right? You have to gentle warm the embryos in multiple steps to prevent cell damage. And when you do so, there is a success, but these procedures are time consuming and labor intensive. Right. So, and you can imagine when I talk about my lab today, and I would give some procedures percentage, I would conclude that vitrification of oocytes and embryos, especially based on the biopsy of embryos, will take most of our time. I would say it's 90%, right? 5% is maybe ICSI, 2.5% is retrieval. And so whatever is remaining, but the heavy workload per day now is biopsy and with that freezing of embryos, but also oocytes. But I will focus on in my talk here on blastocysts. Also, when we look at international data, we are aware of there is an increase nationwide in these procedures, right? So, for example, ASRM published like last year, and their data showed an increase in 1 year, about 20,000 cycles, including oocytes and blastocysts. Yeah, the same publication was coming from Escher, so we can conclude at the moment we estimate 12 million babies born from IVF, and about 4 million coming from frozen thawed oocytes and embryos. So it's already 30%. For many years, when I give these talks, we were stocking at 20%. Now you see this number going up, and I predict, end of 2030, we will have 50%, even more, where we have babies and transfers from frozen oocytes to embryos. So having said that, we have to think about the procedures, right? We do vitrification very successful over 20 years. I started in 2000, but the protocols, they need adjustment. And when you look at publications, there was one work that was standing out by Teal Tyler. He got a reward for this in 2001 and 2 at prestigious meeting here in the UIS, and he showed, that a fall in the 1 molar sucrose for 1 minute is very successful. And I just want to show you our workload to underline when I talk about how busy we are. This is just a screenshot from the last 4 months in our lab in 2024. And you see here just the FATs. I'm not presenting you the fresh oocyte retrievals, but we literally have around 150 to 200 FATs every month. So, and just imagine, the falling so far was like 11 minutes. And if we can cut down the minute per fall to 1 minute, imagine that huge time saver. But before we save time, we have to make sure these embryos do well, and most important, they still have the capability to achieve babies. What you see here, just this workload, it's a very consistent positive beta. But you see also now we do a maturity of transfers with euploid embryos. This is always significant more transfers than with untested embryos. And so what I show you here is going back in time, and we have a lot of young embryologists. They might have never heard of slow freezing. They have no idea what it means because we're all born in the time of vitrification. And for example, this one here is, when we vitrified blastocysts in 98, it took us 128 minutes. Because we used a procedure, an aberrature, a planer, and freezer machine who gently drove down the blastocysts to a temperature of about -40, where we finally were able to plunge. But until then, the plunging, it took us very long. When we switched to vitrification in 2004, since when we vitrify blastocysts in my lab, we reduced this time to 10 minutes. And I can tell you that was a shock for the embryologists, right? Having now not anymore with 2 hours left to do something else, you had to sit on the bench and you had to complete this procedure in 10 minutes. And now we are down to a total time of 5 minutes. So when we freeze blastocysts, we do 5 minutes, 4 minutes in ES, and 1 minute in VS. This is our protocol, how we vitrify blastocysts. As I mentioned, we go briefly in a drop of ES. When we put embryo on top of the drop number 2, let it sink and keep it there for 4 minutes. After 4 minutes, we go through 2 drops of VS, and then in 1 minute, and then the embryo is frozen. So this 4 minutes is a perfect time for ES, because you can also work with at least 4 to 5 embryos at the same time to make it even more efficient. I tried less time in ES and I didn't get a good outcome, so we stick with the 4 minutes. So when I saw this publication from Teal Tyler, I went home, and that was in May 2022. And we have a lot of research embryos, like most of you. They are signed for discarding. We have here signed consent by patients. And so I started with like 20, 50, 60 blastocysts, and I worked with one embryologist to help me to fall this all together. And finally at 666, I said, okay, that's enough. Results are so impressive. Embryos looked so great overnight that we decided in September to bring that in a clinical setting, presenting to my physicians. And since September 22 and 2022, we do with fast warming. And again, the fast warming is, removing the embryo out of the liquid nitrogen and plunge them in TS, that is 1 molar sucrose. You see here just this data, research data. First of all, survival is very comparable. I split these embryos in 2 groups in PGD embryos and in non-PGD embryos. There is no difference in survival. The only thing that you see that the hatching rate is significantly different in embryos were biopsied after 24 hours in culture. And this definitely has to do with the opening we make at the time of the biopsy. Having said this, this is also for us internally an evidence that we have to do assisting hatching on embryos, at least where we're not biopsied, to bring their hatching rate from 77%, 64% up to close to the hatching rate of the blastocysts we were biopsied. That's more than 87%. And this is our protocol. It's very simple. We make one big drop of 400 microliter. You have to make sure your TS is at 37 degrees Celsius. And we have TS always in an incubator overnight. We have incubators where don't be gassed, so we just have 37 degrees Celsius, so that you can start early in the morning. And before we implemented that protocol with that FET number I showed you, I had at least 2 embryologists they started thawing. Now most of the FETs on a daily basis done by one embryologist. He starts at 7 and we are done at 9. And the embryos usually like 2, 3, 4 hours in the dish until transfer, and then they get transferred. And this is just so far our number of transfers. We did more than 4,000 transfers, precisely 4,132. And you see our outcome. Our age groups are based on our society and ASRM. You see we have 4 different age groups: under 35, 35 to 37, and 38 to 40, and over 40. And when you see, between 35 and until 40, so positive beta is very consistent, over 70%. And when you see a drop of about 5% with patients over 40. So overall, in these 4,132 transfers, we see a positive outcome of 71.3%. I want to go more in detail because positive beta is just, giving you a trend. But here is evident that this protocol works by showing you the live births. And you see here we can look at 2,000 transfers because we have now 1,000, close to 1,100 live births. Our live birth rate is about close to 52%. If you look at untested embryos, it's about 47. If you do genetic testing, it goes over 50%. If you look at patients under 35 and over 40, that's usually the patient population on both sides of the spectrum. So one, we can get easy pregnant, the other ones, they are harder to get pregnant. You see here when I split the embryos for under 35 and for over 40 in tested and untested embryos, you see here the benefit of genetic testing, even for patients under 35, where you have a live birth with 53% when the embryos are untested, and you can bring that up to 60% when you test the embryos. And for older patients, it's even more impressive. Usually their live birth rate is under 40%, 35%. And if you do genetic testing, we can push that up to close to 48% for these older patients. And then that's the extreme. I show you patients under 35, tested, untested, but now day 5. And where day 5 is definitely superior over day 6. There is no question in terms of outcome. Day 6 make also pregnancy and live births, but it's definitely not comparable with day 5 embryos. When you see when we have tested embryos for patients under 35, and it's even those 215 transfers, we can achieve a live birth of 65.1%. And when we go to older patients, you see also to patients with day 6, we can get to 53%. You see here the impact of PGD is not as dramatic as we might see it with day 5 embryos. So what does the procedure do? It's definitely simplifying everything, right? It minimizes the handling for the embryos. And when you minimize the steps, involving handling embryos, you minimize the risk. And as the speaker before already mentioned, the stress for the embryologists. For embryologists, making protocols simpler, it gives them earlier competency, and it's a consistency to work with protocols. It's much easier to achieve. It reduces the time of potential exposure to suboptimal temperature and osmolarity, there is no question, right? And finding shortening time would help mitigate potential genetic, epigenetic, and other toxic effects associated with prolonged exposure time to cryoprotectant. And as you follow me on LinkedIn, I get a lot of credits and I get a lot of thank you. One of them is here since implementing the fast rehydration protocol in July of last year. We have seen a significant improvement in our frozen embryo transfers outcomes. Thank you so much again for your effort to enhance embryology practice. It has truly made a difference. And I thank you very much for your attention, and I'm happy to answer questions.
Thank you, Dr. Lieberman. It's nice to hear you, and I'm sure that there must be a lot of questions there. I just want to know, basically, this ultra-rapid vitrification, what we are talking about today, is this factor of effect of cryoprotectants on the embryo is considered in this development of this ultra-rapid vitrification? Is this was one of the factor that long exposure to this cryoprotectant has a negative effect on the embryos?
We have to make, we have to revise all this a little bit. We do vitrification now for many years. And, I would assume, you're in that field for many years. And we always talked about toxicity. It was mostly a concern brought up by people that didn't have any evidence, right? And it was something, it was brought up, but, we couldn't really explain and we didn't see what actually means a toxic effect. What does the cryoprotectant inside? There is one good study by Per van der Swalm, and he's from Belgium. He did a lot of good work in cryopreservation, and he compared slow freezing, as I showed you how long the protocols are, right, to freeze embryo slow. It was 128 minutes compared to vitrification. In slow freezing, and nobody was thinking about and talked about the concentration of cryoprotectant was significantly higher when you vitrify embryos, right? Just to bring that up. If we go now to the shorter protocols, there is definitely something true. We reduce the time of exposure to the cryoprotectant. Let's assume if it's a potential toxic effect, we will reduce that significant, right? In addition, we reduce the time out of the incubator. We all do a lot of precious time and attention to our embryos, put them in a culture, in an incubator for 5-6 days. We're taking care of the gas, we're taking care of 37 degrees Celsius. And then in a sudden, we bring them out because we have to and put them at room temperature. We put them at 20% O2. We put them at 0.003% CO2. So, embryos definitely will not like this, right? So if we can cut down this time for embryos to be outside this very unphysiological environment and be successful, that's the benefit we get from these protocols. And overall,
thank you,
when we look,
explained.
Thank you. If we look at our time, when we compare like the time, our fourth protocol was 11 minutes, now it's 1. We reduce the time to procedure to reduce to 90%. And what comes also with it, besides efficiency, smooth workday, it comes also with save consumables too, right? So you save about 40% on cost for your consumables because you use less solutions too. I'm sorry to interrupt you.
Yeah. Do we have any other questions for Dr. Lieberman?
So no questions in the chat group. If anyone wants to ask, you can ask, sir.
Can I?
Yes, ma'am, please do.
Yeah. Very interesting talk, and I think everybody's looking forward and will be thankful to you for reducing that work time. I mean, it makes a big difference.
Thank you very much.
Yeah, but what is very interesting is that you're talking about biopsied embryos versus non-biopsied, and that's quite a significant difference. Do you also see that in the conventional vitrification protocol?
So we stopped in 2022. Before we froze in 11 minutes and we froze in 9 minutes and we thawed in 11 minutes. And I can tell you there was a difference between genetic embryos before and compared to non-biopsied embryos the same, right? this is obviously the protocol will not affect so much the outcome by now exposing them. So overall pregnancy will be bumped up, not significant, but the most effect is that your pregnancy doesn't drop, you are more efficient doing your workload, and embryos definitely healthier at the time of transfer because of that short time of exposure. And also by exposing them to 1 minute of TS, where exchange of water and cryoprotectant also happens fast. So this is also a benefit by getting these cryoprotectants out as soon as possible, but it has to be in a rate that the embryo doesn't get effect, right? With oocytes, you have to be even more careful. But we have an excellent speaker about this topic, and I see him already. Good morning, Mitch. He will talk about this. So the difference between genetic testing and not genetic testing embryos was pretty much the same before by using the more conventional fructification protocol. Yes.
Thank you.
You're very welcome.
Yeah.
Anytime
Jürgen,
for
thank you
question.
thank you for this insightful presentation. I have like a question in mind. What was during establishing this protocol? What was initially the rationale to change or to refine the protocol? Since now the vitrification has a high survival around the world, most of the programs are successful. So initially, when you refined this protocol, was it like under the pressure of high workload, or just you was exploring the cryobiology of the embryos, or keeping the embryo by 1 minute by like since the inception of ICSI by accident it worked, and you tested this hypothesis. So just that's a reflection. What was the rationale behind it initially?
Right. I usually have a slide, right, in my presentations, and I mentioned that before. As lab director, we all here, we have to be open for everything. Like we have to look for new publications, for new trends. And, we had one publication, and about this one publication followed some more by a work group of Teal Tyler. And he published that for Pacific Coast Fertility or Pacific Coast Meeting and PCRS, and then he published had an oral presentation at ASRM. So there was in a sudden like 2 papers out there. That's where I picked it up. I talked to him, and when I went home and didn't start immediately to implement that, right? But our responsibility as lab director is, because we are the brain of every IVF lab, right? We have excellent embryologists, but we have to define the strategy and we have to give them guidance how we can do better. And so I picked this up and I showed you my numbers. I thought in-house so many blastocysts. So, our duty is to do our homework. This is no questions. But, if I confirm the data others had already published, at that time, very few people picked it up. I picked it up. And when I saw, yeah, it's amazing, it helps. And then I shared it with the community and I put it in a publication. So that's how it started.
It worked.
Yes.
Thank you so much, sir. And thank you. Do you have a question, sir?
Yes.
Yes, please, sir.
Thank you, Dr. Lieberman, for this amazing presentation.
Thank you, George.
I have a question. Are you planning to do any experiment to analyze the gene expression after this short protocol?
The embryos coming. So first of all, the short protocol would be, when we look in embryos after testing, because we vitrify now in about 5 minutes. I think if you might see an impact here, I'm not convinced that we will alter anything in terms of the chromosome status of its embryos and the ability to be euploid or not euploid, aneuploid.
Maybe
right?
coding RNAs, non-coding RNAs expression.
Yeah. So there was some people, I didn't do it, but some people had publication on mouse embryos. And I can send you the reference if you give me your email on LinkedIn or here. And so they looked in certain things internally in mitochondria, in very important parts, very important for the membrane, isotope-free. And they found, that everything this cellular compartment. They didn't look at gene expression, but that they were beneficial, much healthier after this faster vitrification than longer exposure time, right? So euploidy status of these embryos didn't change in their study, and why should it? But they had also better fertilization, they had better blastocyst formation and outcome. And this is also true, and I don't want to say anything about before Mitch talks about oocytes. There is some people they work on this in oocytes. I did that too, but my talk here was supposed to be on vitrification of blastocysts. They see by doing fast freezing of oocytes a 10% increase in survival. They see an increase of 15% increase of blastocyst formation, and overall putting that together to about 10% increase in clinical pregnancy. So also for oocytes, you see definitely an impact. For blastocysts, we solidated our outcome. It didn't go down, or it is not lower, but it is consistently the same, but by saving time and many other things. Is it stress and easy to achieve and learn for embryologists? It's all important. Simplification, always people sometimes blame and burn you for simplifying things. According to Steve Jobs, it's actually much more difficult to find simply protocols and make it more complex.
Thank you.
Thank you so much, and thank you, sir, for the wonderful lecture and a wonderful discussion on together. And I
Thank
would
you very
like
much.
to invite our next moderator, Miss Salia. Can I have a CV, please?
Yeah.
She's
Good
head
evening.
embryologist of International Hospital Kuwait, and ma'am is the executive member of SIG Embryology Middle East Fertility Society. Welcome, ma'am. And
Thank you so much.
Can I have the CV for
Thank
this?
you for having.
Yeah.
Yeah. Good evening, everyone. It's my great pleasure to introduce our next speaker, Dr. Mitchell Chewy. Dr. Mitchell is a highly respected reproductive scientist with extensive expertise in cryopreservation, embryo culture, and assisted reproductive technologies. With his strong background in clinical embryology and research, he has contributed remarkably in the advancement in IVF, particularly in the area of vitrification and embryo viability. As a high complexity lab director since 1995, he has continued developing and applying assisted reproductive technologies, including novel vitrification procedure and over 200 publications. Today, he will sharing his insights on rethinking cryopological principles, ultra-fast vitrification, and rapid elution of human oocytes and blastocysts. Please join me in welcoming Dr. Mitchell. Dr. Mitchell, welcome.
Thank you very much. I appreciate the opportunity to be with you at your fertility conference, and it's my pleasure. And again, I'll share my screen. Sorry. Okay. As you so kindly announced, I'd like to talk about rethinking cryobiological principles as they apply to vitrification today. I would like to first acknowledge El Gallardo for bringing us this interest and wisdom about speeding up the vitrification process, which he referred to as ultra-fast vitrification. He did this in his dissertation in 2018, as well as my colleague Jorgen Lieberman, who's just spoken, who at a workshop in 2022 at the ASRM on vitrification devices talked about his work speeding up the process as fast and furious as he just discussed. And it got us all thinking about a different way. I have no conflicts of interest to disclose. What I'd like to do is share my knowledge to help you understand more about the cryobiology and advantages, excuse me, of this non-equilibration ultra-fast vitrification process. We'll assess the practical value and flexibility of ultra-fast vitrification and warming rehydration strategies. I'd like you to gain an appreciation for the value of validation and verification studies to assess ultra-fast vitrification effectiveness as it applies to oocytes, GV oocytes as a good model, and revitrified human blastocyst discards. And finally, we'll discuss what we've learned in progress and how we've progressed in clinical applications. I'd like to share, first off, before I come to this slide, there was a breakthrough discovery in the mid-1970s by Steen Willitson in a sheep model that showed us that we could deviate from slow vitrification or slow freezing to -80 by simply rapidly freezing embryos plunging them at -38, which is the cell freezing point. And in order to have good viability, he learned he had to have rapid warming. There was a study by David Whittingham, then in a mouse model in 1979, that verified this, that if you slow cool to -80, you must slow warm. And if you rapid cool at -38, you must rapid warm. So we had this correlation with cooling and warming that we understood from slow freezing. Then in 1980, Bill Rawl introduced the concept of innocuous cell freezing. By verifying it on a cryomicroscope, you could see that when you crystallize and have freezing outside the cell, that embryos can in fact survive, especially through the rewarming process where you can see the crystallization, the darkening windows there, yet the embryos remain viable. And so this was the first verification that how cryoprotectants dehydrate the cells effectively and integrate their beneficial effect by binding water and the colligative properties of water with proteins to essentially vitrify the inside of the cell while the outside matrix is crystallizing. So as shown here, then Bill had this analogy that cryoprotective agents substantially increase the viscosity at the intracellular regions, which ultimately cease water from moving, and the cytoplasm forms a metastable glass, which is to vitrify. He then teamed up with his scientific friend, Greg Fay, who was working on the outside of the cell by increasing cryoprotective concentration sufficiently to avoid ice crystallization and have a vitrified solution outside the cell. Of course, they then teamed up and produced the first vitrified mice in 1985. Another concept that we should embrace is the one of elution or diluting cells. And so we know from slow freezing that when we dilute cells slowly, we can slowly pull out the cryoprotectant and replace the water and have survival. This is how we did slow freezing. But then we also learned that we could use non-permeating solutes like sugars to create an osmotic gradient that pulled both the cryoprotectant and the water out and then allowed the water to slowly come back in a stepwise manner, but also, as Jorgen stated, we can now do a one-step approach, which actually historically is not a new concept because Stanley Lebo showed this to us in the early 80s by creating these straws on this side here, loading a large sucrose column with embryos in a small cryoprotective medium. You could then simply thaw this straw, shake it, and in one step dilute the embryo from its cryoprotectant with the sucrose column. And then you could either put this straw into a dish or transfer it directly into a cow. We also applied this concept to vitrification in the latter 1980s. where, excuse me, the vitrified embryo was placed into the straw with a large sucrose column, and the same applied, and we produced both mice and sheep in the late 1980s using this one-step approach. Now, as you've just heard, and this is just a highlight of Jorgen's first published work, his fast and furious approach where he reduced the vitrification time and introduced the one-step concept worked extremely well. But it wasn't quite ultra-fast vitrification. So, as we talked about, we've progressed from this slow model of innocuous freezing where the cryoprotective agent has slowly dehydrated the inner cell constitution of the embryo, allowing the cryoprotectant to bind with water and proteins to create a viscous interior that vitrifies while it crystallizes outside. But then we came along and we started applying vitrification in the 21st century, particularly in the last 15, 20 years, in an egg model where we've used an equilibration or semi-equilibration approach where we dehydrate the oocyte in a non-vitrifying equilibrating solution. And then we have extended exposure up to 15 minutes, allowing the cryoprotectant to equilibrate in further to almost a 90% volume before we come back with the vitrification solution and dehydrate the cell again, but now have fully loaded cryoprotectant in the egg. But we question now in retrospect what the value of this really was, because we know from the slow freezing model that if we just sufficiently dehydrate the cell and allow enough cryoprotectant into the cell to bind the protein and water, why would we need this additional exposure? In fact, we've learned over time that we can change the membrane dynamics by this extended exposure such that although the DMSO and ethylene glycol enters into the cell, it does not effectively come back out because of membrane sealing events. Also, we know from the recent work, as Jorgen just alluded to, from Cho and from Zhang, that we can alter the gene activation process and mitochondrial integrity of energetics. So in essence, we've now learned and are learning more that this extended exposure may actually be harmful to the cells. So then we have Miguel Gallardo's work and the work of Cho, who's duplicated in a mouse model, extending this nice shrink swell curve study that shows us how the eggs are responding. Of course, we know we have the dehydration and the standard vitrification where we re-equilibrate and swell them and then put them back into vitrification solution. And we get further dehydration, which is Cho is defined as a contraction, expansion, contraction model. Whereas in Miguel's dissertation work, he did this 1 minute approach, where in the ES solution, we see almost a 50%, 45% reduction in water volume. And some cryoprotectant is entering into the cells, and then he hits them again with vitrification solution. We have further dehydration down to that about 50% mark. And so you can see this physically here with the eggs. You have, again, like we alluded to in the slow freezing concept, we have this dehydrated mass with enough cryoprotectant to vitrify the cell. We think this is particularly important for eggs because the egg model, although we've come to have it to be very effective, and we've, of course, produced tens of thousands of healthy babies, it has not been a very efficient process because there's been variability, especially among autologous patients, which is undoubtedly linked to stimulations and cytoplasmic maturation. But this seems like the approach where we can at least offset our issues with survival. And so we explored it in a germinal vesicle model, as well as the substandard egg model shown here behind. I move this over. And then what we've shown in these studies, which were reported in December in RBMO, and as well as Jorgen's own germinal vesicle model studies, is that we can achieve very high levels of survival, and we can show that the viability of the eggs is retained because we've gone from GV to mature eggs effectively. We've shown that the spindle apparatus has maintained its integrity. And in both model systems, we have shown that we're able of achieving blastocyst production. I'd like to acknowledge my colleague, Catherine Wozniak, as well down here. So in the first study, what we showed was that we had this control, fresh egg control, and then we had very high levels of survival, both in both ultra-fast vitrification groups with either conventional dilution or rapid elution, which was a one-step sucrose approach. Whereas the conventional model acted much like our autologous eggs. We had about 76 to 78 survival. And in this model, we did see a reduction in viability and with rapid elution, because again, there's more cryoprotectant in the cell. And so to get it all out in one step was quite a challenge. Now, this wasn't significant, but you can see the reduction. These eggs then responded well. In all cases, we had normal maturation at 48 hours, but we did see a bit of a delay in the conventional vitrification group where we had more M1s and fewer M2s. So this may be showing us some toxic effect. Furthermore, we then applied it to our substandard egg model, and we've shown that we achieve this very high level of survival consistent with what we expect in embryos. And in this case, since we're using this donor egg model substandard, we get this higher level of survival consistent with what we see with donor eggs. And in all cases, we saw no changes in development, and we're able to achieve substantial levels of blastocyst through an activated egg model. Here we just show a comparison in their developmental manner, time points through time lapse, achieving these nice hatching blastocysts at day 8. So why is this important, and what are our concerns? And what we know from extended equilibration exposure concerns include toxicity. And this can be different between oocytes and embryos because oocytes are undetermined in their developmental status and have a lot that they still need to accomplish while they are maturing as an egg cytoplasmically, while they're being fertilized. They can still mature. So when we vitrify them prior to being fully mature in the cytoplasm, we know we can offset and affect gene activation events, microtubular filament development and growth, the mitochondrial energy of the cell, and again, the membrane permeability. So what Cho has done in his studies that Jorgen alluded to is had a very nice assessment of gene activation and microfilament formation to show that ultra-fast vitrification more closely aligns with fresh egg dynamics compared to conventional, which was significantly reduced. Whereas in the blastocyst model, we have a more advanced cell stage. It's determined in its development. It has more of a resting dynamics compared to growth as far as its regulators. And so the blastocysts have always appeared to be more resistant to chemical exposures and do so in this case as well. I just want to highlight briefly, I know Jorgen's talked about blastocysts, what our own work with ultra-fast vitrification with blastocysts, and by allowing a 1-minute exposure, We have looked at the elution model like Jorgen's did, not at the same level, but the one-step approach in our lab on these research embryos thawed out worked very well. There's no difference in survival. We've then applied it clinically for the last year with high levels of consistent survival. And in this first rapid ultra-fast vitrification study we presented in 2023, we see comparing two different cryoprotective agents that both conventional and ultra-fast vitrification achieve 100% survival, and re-expansion at 24 hours was high in both groups, a little bit lower in the, this is a glycerol ethylene glycol group. So the only point I'm making in this panel is that when we use different cryoprotective agents and we use different concentrations, but particularly in this case, we have glycerol instead of DMSO or ethylene glycol, we need to revalidate and verify its effect using this technology. And we would need to look at probably longer exposure times or different ways to do things. And then we have applied ultra-fast vitrification in day 6 embryos over the last year and attained acceptable levels of implantation and survival. We then produced a secondary study using an ethylene glycol solution without DMSO and reassessed the ultra-fast model from with a 4x4 crossover study, basically, where we have different exposure lengths and then different vitrification solution exposure lengths. And we cross that over. And so sorry. We cross that over from the 1 minute, 1 minute approach up to, say, the 4 minute and 1 minute approach that Jorgen has applied. And a bit of our surprise was, although we had 100% survival in all groups, including the extended vitrification exposure groups, the level of viability at 2 and, or expansion of the blasts at 2 and 24 hours in the gold group was significantly altered, with the 1 minute, 1 minute group having reduced expansion at 24 hours. And the 2 to 3 minute ES exposures had all acceptable levels of viability at 24 hours. So we think there's a window here that allows optimum effects through this ultra-fast approach or faster approach up to 4 minute exposure that Jorgen applies. Although the 1 minute, 1 minute works, there's a subset of embryos that aren't remaining viable at 24 hours. So maybe our 50% rate at day 6 could be higher by doing a 2 minute approach. So when we have this data, we start applying it clinically to those groups, and we are waiting on those results as we speak. Well, if fast and faster wasn't enough, we're now gone fastest. And now we're looking at some preliminary work out of China. We've looked at direct rehydration. And so going beyond the one-step approach of an embryo into sucrose, we're now warming embryos directly in GMOPs and bypassing sucrose altogether, and seeing its effect on embryo survival and development. And the preliminary work is very exciting. The Chinese group did produce pregnancies, but they didn't do any validation work. So we wanted to take a step back and look at it first. And what we found in a recent study was that we had 100% survival in both groups. Well, in the GMOPS group, which wasn't different than the sucrose, one embryo didn't survive in this group. But again, we're looking at discard embryos and the viability, grades of embryos, or we try to keep out C quality embryos. Again, subjective grading can be a factor. But at 2 hours, we saw no difference in their re-expansion and survival. And at 24 hours, we saw similar development between the groups. And we took these out an additional day to look at further blastocyst hatching and trophoblastic outgrowth production. And we showed that, again, this GMOPS group is indicating that it's still viable. Not only did it prove sustained viability and the desire to implant through its outgrowth, we also were doing a study in contingency with another study where we're looking at fluorescent lifetime imaging of embryos. And the importance of this is that this allowed us to look at 700 nanometers on a confocal microscope. We were able to look at energetic markers like NAD and FAD to verify that these embryos were indeed still metabolically active. And so in both these groups, we achieved this effect where we're able to image these embryos at 2 hours and at 24 hours and show that they're still very energetically active and growing. So overall, we've gone further to defy cryotheory and shown that the osmotic responsiveness and complete survival of blastocysts can occur by a 1-minute direct rehydration approach. I'd just like to thank my team of embryologists, our medical director, and appreciate the opportunity to be here today.
Thank you so much, Dr. Mitchell. Thank you for sharing this all with us. I have a quick question for you. I was thinking of it during the preparation of this session. With the ultra-fast vitrification and the rapid elution, do you think we need to revisit the cryoprotectant concentrations and the exposure time to minimize any toxicity?
Well, I think it's a unique opportunity to look at I think we need to look at new vitrification solutions. I do. I think DMSO is proven to be a very effective cryoprotective agent, but it is known to have toxicities. Now, maybe in a very brief exposure, we limit that. But I do think as scientists, I think it's time now that we're reapproaching our theories and showing that these cryo theories that we thought were hard and fast really are quite flexible, that we do need to look at other cryoprotectants. It's just hard to do because these commercial companies are invested in their solutions. They don't want to they have something they can market, and it's very hard to get them to change. But I think, personally, I think that's why I started looking at ethylene glycol by itself and to see how effective it could be so it could reduce some of the DMSO effects.
Yeah. If we can take from you a quick advice for the lab or the IVF units who are thinking seriously of starting the rapid vitrification or warming, from where do you think they should start? Is it the right time, or they need to wait, or how can you guide them to start with it?
Well, again, I think different countries have different regulations. In the United States, we are pretty open to research, and especially in California. It's a very liberal state. So we have the ability to research or discard embryos that once patients have properly consented to that process, as well as the immature eggs. It's part of our standard IVF protocol and consent that non-viable cells, such as immature eggs, because although GVs can be matured from stimulated cycles, it's been proven that genetically they're not stable and they're not really good embryos to keep. So we don't keep GVs. So these models are really exceptional opportunities for the lab to learn from, what we call research and training of non-viable research, non-viable studies. We assure patients after our assessments And it's a very good opportunity for people in the lab to get a feel for the effectiveness of these changing techniques. So I do encourage starting there and just creating studies to validate and then verify the effectiveness of maintaining the integrity of the cells. Yeah.
Any other
Can I
questions?
ask a question? Can I ask a question, please?
Yes, ma'am, please.
Yeah, please.
Yeah, so that was excellent presentation there, Dr. Mitch. And I believe your work would be a reference point for many people to start with this procedure and protocol. One simple question, whether it is any method, slow freezing, the normal equilibration vitrification method, or the ultra rapid method, the oocyte vitrification remains a challenge compared to the day 3 and the blastocyst embryos. And what you have done was the experimental testing of this protocol on the immature oocytes, right? In your phase 1, the part 1 of your study. So what difference in the survival rates did you find between immature oocytes and mature oocytes? Because I believe you went ahead to do in vitro maturation of those warmed oocytes as well. So
Yeah.
did you find any difference in the survival rates between immature and mature? And would it be something like a serendipity to for us to start freezing the immature oocytes?
Yes, I would start with the immature oocytes as a model, and so you get comfortable with the technique, but you'll be impressed that now I do think we need to do a little more research, but we are already applying this clinically because in our mind, to have eggs survive like they're embryos is a first step that's necessary. And then if those embryos, we don't know, what we don't know is how efficiently and effectively they will develop with, let me back up and say that the problem we've seen with conventional vitrification is the variation in developmental potential. So we have a lot of cells that don't develop, we have delayed formation. And at this point, we don't have enough data to confirm with ultrafast that we can change that dynamic. That may be something that's just associated with the cytoplasmic maturation of the egg relative to stimulation, and we may still see some level of variation in that regard. But we have the underlying evidence based on the mouse model that by simply exposing them to less cryoprotectant for less time, we should, in theory, have less toxicity and bypass some of these problems. And this is what we're going to be proving over time. But we know that it's safe. We know that it's not going to be a negative necessarily based on the mouse model work with gene activation and microfilaments, as well as Dr. Aiden's studies with his donor model. He's also confirmed some of the more molecular aspects of the cytoplasm of the egg being normal under ultrafast vitrification, and they have quite a few. I mean, I haven't seen the data, but I know that they have over 50 ongoing pregnancies, and by this time probably births. So we know it's working in the human. In our own model, I can tell you that we used it in a donor egg model that because we want donor eggs to be perfect when we market them and sell them for patient use, there's a substantial number of eggs that get left behind. And we use those in this model, and we were able to prove high levels, again, 100% survival, as if they were blastocysts. And we were able to achieve comparable levels of development. So that was done in the second phase. And we've now continued this into some clinical studies and trials. But I will say that when the egg quality is compromised, although in many cases we're still seeing 100% survival and very high fertilization and 50+% blastocyst production, we also have situations where we see some variation, but we believe that is related to the substandard egg quality. So egg quality may still play a role in giving us poor results. So we should be open-minded about that. This is not a cure for, all bad eggs to still survive. They may not survive.
Thank you so much. Thank you.
Mitch, can I ask a question to you? It's a very small practical tip question. What percentage of protein did you use in direct warming in GMOPs?
We just used the commercial complete solution. So it was I believe that would be a
5 mg per ml.
50. Yeah.
Okay.
Nikita, sir,
We
you
did
can
not modify it.
ask the question.
And I can tell you that from a practical standpoint, the beautiful aspect of it that my embryologists are loving, which I noticed, is that instead of the embryo floating to the surface, it goes straight down.
That's
It's
right.
like it's right there. It's just easy to see.
Nejati, you have a question.
I have a question,
Yes, sir.
but it may be a long one, but I can wait for the panel or I can ask directly. I don't know.
Let's go.
Okay, let's go. So I remember that initial days of vitrifications that we start to use commercial products. I think it was the year of 2006 or 2007. And according to the protocol at that time, but there were certain, duration of cryoprotectant exposure. That's why we call this equilibration solution. And for some embryos, I remember that it's recommended to extend this kind of exposure in order to increase the survival. So, I mean, that was something that I'm really kind of confused based on the current results, because in almost all stages, we didn't see any significant differences in terms of survival and the potential of embryo development. And I remember, for example, for some oocytes, we needed to expose the oocyte more of the cryoprotectant because of this relatively necessary expansion of the cytoplasm. And it was true also for the day 3 embryos. That was my first kind of question and comment. And the second one is that in order to warm these oocytes on embryos, we had to be very careful about the carryover of the solutions even. So we needed to, or we are required to really create a smooth kind of gradient in terms of sucrose concentration. And any kind of non-viability at the end that could be related with this kind of not very well performing the warming procedure. And the third one is that for some cases, some people even recommended the assisted hatching for the blastocyst, increase the survival and then the implantation. So according to the current state, none of them seem to be necessary at all. So I think we need to rewrite the whole cryopreservation book.
Well, we'll leave that to Jorgen. We can get that started. But
he's right. When we vitrified blastocysts, for example, in 2004-5, it was very, very different. The exposure time was about 11 minutes, but we connected drops, right? So we increased the concentration of the cryoprotectant by connecting drops. And what we did, we observed the shrinkage and the re-expansion, right? Every time when an embryo was shrinked and started to re-expand, we increased the concentration of the cryoprotectant to shrink it again. That all works very well. But now we switch to a different way. We just put them in one solution and let everything work by itself. This is a simplification, because I can tell you, when we freeze blastocysts, we would have a different opinion when an embryo is expanding or shrinking. And so, the impact of the embryologists at these protocols was tremendous and very different. It depended so much on the technician, right? But now, giving a time by putting your clock on 4 minutes and let the embryo just in the exposure, in the equilibration solution, makes the whole thing more reliable, more consistent, and that will be reflected in the results. And as I mentioned before, we talk about fast, but now we talk about, bringing a dogma down in cryobiology that was there for many, many years, and it was nothing wrong. We just explored that we can go around this dogma, and the dogma was stepwise dilution, and we can actually do it now in one step, or even as Mitch showed, and I did that too. I just didn't talk about because I think we have to move slow. Direct rehydration is a visible option.
And for that matter, Jorgen, I believe even collapsing artificially, I mean,
Yes.
yeah. So like my experience is a little different, that I'm not practicing any artificial collapse and still getting good results with the blastocyst. So as
Yeah.
yeah.
I don't have a
Yeah.
doubt that you get good results, but when you want to move to the short exposure times, I would recommend. If you don't collapse them, and you will be fine, but you cannot go with 4 minutes. You have to stay longer in your ES.
And we
I
are
would like
still
to
using the
comment.
same concentration. The products, the concentrations are the same for all the products for like
Yeah.
15 years. Yeah.
Well, I think when we moved to vitrification period, in the animal model as well as in the human, eventually the human, I mean, humans 10, 15 years behind what we started with the animal. But we were thinking in terms of speed and efficiency, right? And so slow freezing takes hours, and all of a sudden we have a technique that we can do in 10 or 15 minutes. So we just thought in terms of cryobiological principles that we want to minimize osmotic stress on the embryo. So we just created shorter protocols that we thought, oh, this is short enough. I don't think we really fully tested the limits of how fast we could do things. And so we were just comfortable with this 10 or 15-minute approach. And we said, okay, we're going to do dilutions in this manner because we want to ease into these more concentrated solutions. We really didn't test it. We really didn't test the flexibility of the blastocyst. Blastocyst has proven to be extremely hardy cell type. Yeah, I mean, you can just keep banging on it all day long and they develop. So so that's really the first part, is that's why we're now rethinking cryobiological principles, because we've become so comfortable and we're spoiled. I mean, we had good success to begin with, and we didn't really challenge it.
Yeah.
And that's really the problem we have with the egg model, is that we got comfortable with that it was much better than slow freezing. And if we just tweak this warming rate, we can get better survival. And if we kind of use the donor egg model because the donor egg banking business kind of dominated egg freezing, as you know, in 2010. And the donor wasn't a great stimulation cycles, good donor eggs. And so all of a sudden we had these 90, 95% survivals, and thinking, oh, this is the way we should go. But it was as much to do with the stimulation protocols and the young eggs and all of that gave us this bias in our technique. So we've just got to the point where we can challenge things. And to your second question, it is important still, but again, less important, because we realize these cells can adjust on their own without significant dilution processes. We don't have to be as gentle on them as we thought we would. So I still adhere to a bit of washing, but you can just do that by pipetting in your drop or in different areas and then moving straight into culture. I would just add, I forget the third part of your question, but I think it had to do with
so we had
changing
to
the
rewrite the
protocol.
book. Yeah.
Yes,
Rewrite
changing
the
the
book.
protocol. So yes, we kind of do need to rewrite the book. Unfortunately, the book just came out again, and I don't think Jorgen and I got to throw in any of our nuances on the newer technology.
Start writing the new one immediately again.
Yeah, exactly. I would like to add, I'm sorry, I pulled at the wrong slide set. I had kind of changed my talk a little bit, but one slide I wanted to add at the end is that we recently here experienced severe wildfires, and our clinic was on the border of evacuating from those wildfires in LA. And so we had to vitrify a lot of embryos at the one cell stage. And I will say that I applied Jorgen's fast and furious approach at 4 minutes because I hadn't tested zygotes at 1 minute. So I said, okay, I'm going to be a little bit more conservative like Jorgen and do 4 minutes. And I will tell you, I had 100% survival on 2 PNs, which is not a surprise, and very good blastocyst development. So, it seems that all stages are amenable to these changes.
My only negative comment could be that, the new generation of technicians and embryologists are not readers, they are doers. So, so when we rewrite the book, we have to take care of it very seriously.
So thank you so much,
It's
sir.
important.
And there are certain moments when I was feeling like me sitting here and listening to all the top brains of our field and all the seniors. It is so excellent to hear all of you here. Thank you, Mitchell, sir. It was a wonderful lecture and for all your insights. And I would like that we can continue this with the panel discussion itself. And let me invite all our moderator and the panelists together, and you can join us there, sir. So can I have the CV for our moderators? We can continue the same conversation. It was wonderful, sir. So today we have two brilliant moderators here. I'd like to introduce Dr. Rajvi Mehta. Ma'am has worked in the field of ART over 3 decades, and she is a wonderful speaker and an orator and has multiple orations and IFS, Iran, Ashray, Germany, everywhere. She's a treasurer of Academy of Clinical Embryologist ACE. She's also the chief editor of ACE newsletter, and ma'am is in charge of IFS SIG in holistic medicines. And currently, ma'am is the academic consultant to Cooper Surgicals and scientific consultant to Trivector Biomed. Welcome, ma'am. Raju ma'am, are you there?
Yeah, I'm there.
Yeah, I'd like to invite Miss Alia again. Welcome, ma'am. And ma'am, will you like to introduce our panelists? We have expert panelists, brilliant panelists here all together with us.
So we have Dr. Sanjay Shukla, an ex-past president of ACE and the brain behind iHERA. I think everybody knows him here, and I think we would like to spend more time on the discussion. So, Dr. Sanjay, pardon me, I'm moving ahead. So we go for the next, Dr. Bindu Chimote. Again, she has been very well known to the Indian audiences. She has been in the field for a very long time, and they've always been presenting. She and her team are always been presenting at ASHRAE time and again for 17, I think, how many years? 10 to 15 years or maybe more. And she's been a very active embryologist. And then we have Dr. Sujata, and she is the current president of the Academy of Clinical Embryology. She's the head of Embryology Nova with very vast experience in the field. And she's also American Board of Bioanalysis Certified Embryology. And she has worked in various capacities in various places in the past. I ask now my co-moderator, Alia, to introduce the other 3 panelists.
Yeah, sure. We have Dr. Fadi. Dr. Fadi, he has a PhD in and he's a scientific manager and the lead clinical embryologist at Cedra Medical Hospital and Research Center in Qatar. He is an ISHRAE certified senior embryologist with more than 15 years of experience. Also, we have Dr. Georges Pride. He's a scientific director, researchers. He is an embryologist and lecturer at Beirut Governorate in Lebanon. He's an experienced embryologist and he demonstrated a history of working in the hospital and healthcare. He's a well-known in his research and in his background in the embryology. And next we have Mr. Hassan. He's an assistant executive director at the medical services in the Department of Reproductive Medicine at Hamad Medical Corporation in Doha, Qatar. He is a certified and a leader auditor, and he is a very well-known embryologist with huge years of experience.
I guess
so
you
welcome
put the wrong photo here.
photo. Yeah. Yeah. That's your photo.
That's me.
So
Yeah,
yeah.
it's just not the same face.
Doesn't look familiar, huh?
I was a little bit hesitant. Yeah. So welcome
Dr.
all.
Haitham from our department.
So welcome everybody. And actually our panel had started before we actually started the panel because there
Yeah.
was so much of discussion happening. And like Nidhi said, we could have continued. However, since we have a formal panel and we have the other panelists here, I also welcome the previous speakers to put in their wisdom when we are discussing certain aspects. So we have limited time and I will quickly go ahead. So all this while, for years together, IVF, ART was all about, on efficiency, precision, safety, and we always talked about patience. Like embryologists should have patience. And now everything is shifting towards speed. So why is this whole shift in speed? I mean, in all aspects, we want to, one aspect is for the case of the embryologist and also exposure. But why this shift that we are seeing in the last few years? So we would leave it open to anybody to speak to start with.
Yeah, Rajni.
So who would
So
like-
interesting question. So certainly the demand for faster workflows in IVF is driven by a combination of industry growth, number of IVF cycles increased, staffing limitation, number of embryologists needed, technological advancements, including AI and automation, and the increase in complexity and time requirement of modern IVF. So that's the pressure. We don't have staff, number of cycles are increasing, and we need to manage the schedule and the workflow. That's from
So
my side.
should we
Okay.
say it is primarily embryologist driven, or it's also concerned for the embryos?
Okay.
Yeah, Dr. Sujata.
So, Dr. Rajvi, like how I would like to look at this is, see, more than speed. Say, if you're talking about vitrification. Now, when we find out that there is no need to expose these embryos to a particular salt concentration or a salt solution for a long time, why not? Okay. On the flip side, it is also helping us in organizing our workflow. So it's an advantage. Now, the second thing what I would like to mention here is, you had rightly pointed out about the exposure. If you look at David Gardner's book, like they say, you establish IVF units in residential places where there are no, industries and traffic and things like that. But the scenario is totally different now. Like we have our IVF units in the middle of a busy, place where there are a lot of traffic, where there are petrol pumps and so many other things. Now, if you can reduce the exposure to the ambient atmosphere, how much ever you have an AHU, how much ever you have filtration system, still, like that is some area which we have not really got to know more information about what kind of an air quality is going to impact on the outcome. So if you have a method or a technique which actually, like reduces this exposure, why not? So this is how I would like to look at this speed.
Yeah, so just to add to what Dr. Sujata and Dr. Fadi have already said, so it's about we are dealing with biological material, and as Dr. Sujata said, the exposure time. We have to be very quick in whatever we do. So exposure time to the ambient environment, and of course, we are driven with the pregnancy. I mean, our goal is pregnancy. So the time, reducing the time to pregnancy. So how efficient can we be in doing our work so that the time to pregnancy is also reduced? So time I would look at in three different aspects. One, with respect to response, that is quick. Let us be quick in our responses in the laboratory. With respect to the procedure that we are performing, for example, ICSI. And the third is with respect to the process. So now this process thing, whether, I mean, that we cannot reduce the timing of fertilization. If it has to happen at that time, it will happen at that time. The embryo development, which we cannot reduce. But then, yes, with respect to vitrification, what we believe that was the process. Now we are coming to a time when we are talking of an ultra rapid method. So time with respect to response, speed of the procedure, and speed of the process. So these are the three aspects I would like to focus on with respect to speed.
Okay. And I think the first thing that comes in is what Dr. Sujata said, that exposure. We are presuming that our environment is ideal to that in the fallopian tube and the uterus, but it is not. So and we are getting a multiple benefits, when we're looking at that exposure time in terms of the workload Dr. Fadi said. I mean, if it's going to get you to do so much more, why not? Yeah, Dr. Michelle?
I just want to add to those comments. I think those are all very valid points, and I think they express. I think basically our key was to show that embryos will survive and that eggs will survive with the exposure. Once they have survived, then all aspects of the shorter exposure, I think, are potentially beneficial. And to the point of one of your colleagues' questions, what have we done with respect to looking at transcription and other things? I think all these are important things to still study. I don't have a laboratory where I can do that. There are lots of scientists out there that hopefully will follow up on our studies and validate what we're saying. But in my mind, as long as we're getting cell survival, it would just make sense that the toxic exposure is much less by having a reduced time, which is to your point with air quality and other factors. So I think it's all really exciting. I just thought of something though for the first time that really scares me, and that is that I don't want to be replaced by a robot. I don't want things to become automated, but we are making it easier for that to occur. So,
yeah, George.
I would like to say something to this two sentence. It can be misleading, especially the second one. And we have to be very careful. IVS has a traditional focus on efficiency, precision, and safety. I would like to say nothing changed. We do the same. We are still careful. We follow our protocols. And I think you just want to just stim out our mood. But with the second sentence, I have to be careful, right? Pushing for speed in IVF. Our talk today is using 3 times the word fastest, but in a different context. It's not, pushing our embryologists being faster, being less careful. It's about embryos and oocytes by giving them a better chance to survive low temperature by exposing them less to cryoprotectant, right? I just want to make that clear, because if you come with that second sentence, that can be very dangerous for people that pick it up and put it in the breast. This is not our intention, right?
No, I would make it very clear. We are not talking of speed for the sake of speed. Speed so that we have minimized exposure to the toxic elements. And I think one would say the first breakthrough is when we had an open mind, or you all had an open mind from the dogma that we needed so much time to dilute out all the toxicity. So I think that was possibly a bigger breakthrough, I would say, to have that thought process to think and go ahead.
Yeah. Yes.
Yeah, George. Yes, George. Go ahead.
I will continue from Dr. Lieberman. I will focus on the first part of the question. Is really IVF has traditionally focused on efficiency, and with the example of add-on using a lot of techniques with no or limited evidence that it is effective. So I think, like Dr. Lieberman is saying, we have to work with caution, to pay attention before implementing any protocol in the lab.
Yes, totally agree to it. Alia?
Can I have additional comments?
Sure.
Yeah, sure.
Okay. The first one is, so of course, the rapid or let's say one-step vitrification and warming has been a very good example for the other operations in the lab. But we always undermine, let's say, the other procedural denudation, microinjection in a busy IVF lab setting. Because if you have, for example, 10 ICSI cases per day, and when you spend certain time for each kind of procedure, it takes more than maybe 3 hours from the first case to the last case, but the next day you start to score your embryos at the same time, meaning that your time frame for the embryo development and the scoring could be shifted unintentionally. So if you try to reduce or make everything faster and try to have everything in line with the time frame, it could be ideally more beneficial. And the second point is that one of the authors is Fadi, in fact. So we still having a big gap between the current way of working in the lab and what was kind of defined in the current guidelines in many other international societies. So the complexity of the lab work in today's lab is completely different than 10 years ago. But we still have to struggle with the same guidelines. So you are having difficulty in finding, let's say, or increasing the number of experienced staff in the lab. So having everything faster could kind of balance.
Yes. Alia?
Can I?
Yeah, I mean, you know, we have to also remind ourselves when we talk about fast, generations changing, right? We have always generations, everyone has a name. I'm still a baby boomer. When we have this XCY, and you know, and people, younger people focus more on balance life and work, right? This is a very important aspect. We many years just didn't put too much attention on what I do now, especially for my stuff, because I want to retain my stuff, right? And it's important to keep them working, but also give them time besides IVF, because we all have something else besides our work. And it's very important to get time for this to regenerate and be motivated coming back to daily work. So this is also a part where, you know, procedures responsible getting shorter, efficienter, because it gives us more time altogether to balance work-life.
Absolutely. So we are speaking with reference to, yeah, please go ahead.
I'd like to add to one of the points that was brought up earlier about the new generation, and to Jorgen's point, I think it's important that, I mean, we are dealing with a different generational mindset, and in some cases, in my lab, I call them the now generation because they just want everything now. But it's, you know, I think the important thing as us as leaders, as older established embryologists, and I will say the newest version of that book, we made sure that we updated the history quite a bit so that it's not lost, because that's what we need to maintain. We need, even though we're going to move to faster methods, and these embryologists want to do things just by the SOP, it's really important for us to teach them, to still teach them the basic principles, and so they understand why they're doing things. They're going to do things by the book, but it's important for us as leaders to teach.
Yeah, Anya.
Can I add something, please?
Please, Nagam.
Oh, sorry.
Yes. Please, Nagam, go ahead.
I can go ahead after you. Go ahead.
You can answer my question too. Speaking about the risks, especially in our work with the sensitive materials, we are doing that. There's no go back step. So what are the potential risks we should think of when we are working faster, and how can we overcome them? Nagam.
Yeah, that was the thing that I was about to talk about or comment on that. I believe like every setting is different, and every IVF lab has a different setup that we need to consider. So I always believe in a change one thing at a time. So when I start doing the ultra-rapid warming of cleavage stage embryo, I couldn't go for also at the same time with ultra-rapid freezing. So this is something that we need to be careful with. We have great results coming from many really good researchers and IVF lab directors, and they are already validated and proved their reliability and credibility. But the thing that it's not about that. It's about Like we need to test every procedure in our setting before we can go ahead. And I believe that this is very important to ensure that everything in our setting is okay with this new change. And step by step, we can move to the next change and validate it before we implement it clinically in the lab.
Yeah.
Yeah.
George?
I may go over Alia's comment.
Yes, of course. Go ahead.
Regarding safety, like the risk they may take during if they will accelerate or to go fast. As Naga mentioned, it depends on the lab. You know, if you have a busy lab, you have a high number of cycle per day. For example, for us, we sometimes we reach 15 and 16 cycle per day, case per day. The setup of the lab, it's really important, and you have to take all the measures from quality control, environment control. For example, risk of mismatching. So you should implement, if you are busy lab, you should implement electronic witness system in a way that all the embryologists will be less stressful when it comes to mixing up things. Organizing your workflow on daily basis, give priority to utilize the new techniques or new procedure, starting from the andrology lab, for example. Instead of wasting like half an hour or more doing sperm preparation and using density gradient, you may go for migration technique. It's much faster and will give better preparation for the sperm. Utilizing the time lapse instead of taking the eggs and embryos on daily basis out and in from the box incubator, you can utilize this time and it will shorten the time. I think working fast not necessary to reduce the time of the technique, or like Dr. Nagati said, we cannot compromise the mother nature. We have to follow the procedures, but we can make it fast by mean of utilizing the time. Reducing the wasting time during incubation. For example, when you do after the egg collection, instead of waiting 2 to 4 hours, you can do 2 hours, but you have to start like doing the denudation for the eggs after 2 hours or maybe less, if you have controlled environment. For us, we are using IVF chambers. From the minute we do the egg collection, we minimize it maybe to 1.5 hours, 2 hours. But we do denudation immediately. We can do ICSI even because everything controlled. We don't have any issue with that, and we have excellent fertilization rate and blastocyst rate. So it depends on the lab setting and on each different setting of country or centers.
So let me ask you: did you start any of the rapid techniques for the vitrification or the worming?
Warming, we just started, just maybe last week.
Ah, really?
Yeah, and
how is it so far?
We didn't get the pregnancy yet, but survival rate perfect. We did hands-on training. We were the first in the region actually to do that in Qatar, in Hamad. And we have 16 embryologists, and we have 100% survival rate doing on and abnormal embryos, and survival was excellent. No issue with the ultra fast.
Well, we will be looking forward to see the result.
Yes, definitely.
Yeah. Go ahead, George. Can you ask your question, please?
So I am more conservative. I would say that before implementing any new protocol which may have potential risk, it should be tested in RCTs and randomized control trial, or having an evidence meta-analysis showing that this technique, this protocol, is effective and is safe. So I am more conservative before switching to any new device or any new technique to have any evidence showing that this technique is safe. It will not at least cause harm for the patients.
No, I agree, George, but someone has to provide the evidence. So if we wait all like you, where is evidence?
Yes.
So I think we should test this in RCTs. What do you think?
Yeah. Yeah, of course.
And to add to your comment,
more data we get, there is nothing wrong. It convinces more people. There is no question.
Yeah.
And to add to your comment, Jorgen, I remember Birol Aydin has done a lot of work on the efficacy and safety of outside ultra fast vitrification and
Mhm.
warming, and with respect to epigenetic effects also. So,
Right.
which is very convincing. And if something very sensitive like oocytes can withheld with this thing, I'm sure the embryos are very robust.
Yeah.
So just
He
to
talked,
add a, that's okay. Please go ahead.
Yeah, just to answer this question, how do we mitigate the potential risks? Like someone just mentioned in the discussion that was going on earlier, that the present generation knows just how to do. They don't read. So first and foremost, the basic thing is for the embryologist to understand the basic process and procedure before they start just following blindly the SOPs, that, okay, this is the protocol, 1 minute here, 1 minute there and off. So they have to understand the basic process, why they are doing, and what is actually happening to the gametes and embryos while they're doing this process. So if they understand and do, most of the things can be solved.
Yes.
Yeah, and you know, coming back to George's point, that is an excellent point. There is no question. You know, when I published that on LinkedIn, people took it on and experienced it. But you know, there was always the concern and the question and demand for a publication, right? For a peer review paper. And now we have the peer review paper, and that's where, you know, we go along. That is an evident, I think, for everyone at least to look into this and not look away.
Yeah, I don't think we can wait for commercial industry because once they lock into something, they're not necessarily locked into the right thing.
Yeah.
And I think, we just have to test these things in a careful manner, which I think Jorgen and I have done. That's why we waited on the publishing our two papers together so that we could validate how this model worked in a stepwise manner. And now we are also applying it slowly. We applied it over a 1 year period of time on day 6 embryos, not all embryos. And now we're integrating all embryos. But again, safety is of paramount importance, as you've all pointed out. But again, technically, there's no aspect about reduced exposure that would make these less safe. So I encourage individuals like Dr. Georges, if you have the capacity, you certainly have the knowledge to look at some of these other aspects of molecular biology, like Dr. Cho did. I really encourage you all to look at the Cho paper as well as the Zhang paper. That Zhang was probably one of the most eloquent studies I've ever reviewed. In a stepwise manner, they showed that a particular gene activation process affected protein synthesis, and it did so because of conventional vitrification. So, yeah, it's a big step, but as long as we validate properly, I think we're safe.
I think I would just like to add here, like, for all the young embryologists and people are talking, they do their stuff, they don't read. The fact of the matter is that this protocol has not just come out of the blue or out of somebody's head and says, I want to reduce time and I brought down. There is a whole series of experimentation and, you've beautifully shown how you did all the permutations, combinations, and you have come down to show it is as safe as conventional and in fact better. And that you're going to, it looks like we may even shift directly to buffer. So, which is very, very fascinating. So, please do. I think we need to make it clear. And we're talking all this about safety. But one thing I would like to ask, when ICSI came in, everybody jumped onto it. Did we think how invasive it was? Did we think of, we are putting in PVP in there, we are putting in oil in there? I mean, it's God's grace. We didn't have disasters, but we didn't ask all these questions then. So I'm not saying we repeat it, but the fact is that we need to bear in mind that we can't hold on to something because our minds were dogmatic that this is the way it has to be done. That's where maybe we were taught. And well, I think there's a lot of data coming in. There's a lot of physiological explanation to it. So yes, I think we definitely possibly see this
Dr.
going
Rajvi,
forward.
Dr. Rajvi,
Yeah.
that is what exactly I was having in my mind. Like after so many permutations and combinations, the present, or the whatever we were using, the vitrification solutions were developed. I know, like, Professor Ali he has tested, I don't know, close to 300, 400
Yes.
permutations and combinations. And
Mhm.
I'm really surprised that, like whatever, it's like my whole life is a lie kind of a feeling that, after all that, now you just say that, oh no, you don't have to do this. You only have to, shorten the exposure time. Then again, the next thing is like, we didn't ask for any RCTs then. We just, okay, they did it and we did it.
Yeah.
Yeah, but you're all long enough in that field. How many of these events we had in our life in IVF? Just
Yes.
think about sequential media, right?
Yes.
Changing the media. And then in a sudden, we got a single step media because we provide it and the embryo takes what it needs. And when low oxygen, right, coming back from 20 to 5%. So there is a lot of things they helped us improving and is beneficial for parents to achieve their dream of parenthood. And everything was done in eloquent studies, and there is no rush. Nothing would survive here by being fast and want to put it out because you want to make a publication. Nothing would survive, right? This is a tough contest here, and we have excellent reviewers like Mitch or myself, I think. So we don't easily let things go. With ICSI, that's a good point. You would argue we should learn from ICSI because it was not a good example. But again, we have to say, if we wait like 10, 15 years, because some people asked for live births from babies that were born from ICSI, we would not have ICSI for so many people. They would deal with male infertility. They have to wait for 20 years, but we don't live forever, right? So
Yes, you have to balance it out. I mean, we can't wait for
yes,
live births and
Yeah.
prevent so many. But
yeah,
I think it's also our mindset because,
yeah,
like
I
Sujata
know.
very rightly said, for so many years, I have been doing this, I've taught this, and suddenly you tell me what my entire premise on which I have worked and studied suddenly crashes
To
down.
say,
Yeah, but
So
that's the
that's
beauty
all of it.
that's the beauty in our field,
Absolutely, absolutely. I
to,
mean, it's just,
to
yeah, I
save time,
think
we can
Fadi, I think
do
saying
multi-center
something.
studies.
One comment also. I agree with George and Jürgen at the same time. We know like level 1 evidence or RCTs, but we remember for oocyte vitrification when ASRM in 2012 removed the label of experimentation. It
Right.
wasn't based on RCTs. It was based on cohort studies,
Retrospective,
just waiting and balancing the benefit of vitrification with the implementation of the technique. So sometimes RCTs, that's the ideal, that's the level 1, but oocyte vitrification and ASRM labeling as experimental also is a good example.
If I could add just briefly, somebody mentioned Dr. Ali, and I think it's important to say that Muhammad Ali's contributed vast amount of information to the field. And I remember Dr. Ali said he always thought that the VS14 solution he developed was the best. That solution has never been commercialized, but it should be. It really is a tremendous solution. And that's we've actually been looking at it now, and that's our ethylene glycol only solution. So if there's anybody out there who's got commercial influence, I think that really needs to be looked at. And I thank Dr. Ali for bringing that to us. The other point is, I do think somebody mentioned how we just jumped into ICSI, but ICSI really did revolutionize male factor infertility, right? I think we truly are on a different plane of revolution now. I think this is a new part of our field that is going to change things greatly and make improvements. So I'm really looking forward to that.
Please
You mentioned
correct me if
yeah, okay, go ahead.
Mitch, please correct me if I'm wrong. I could remember the 1 minute elution time was mentioned by none other than legend Peter Mazur in his one of publication long back.
Yeah, perhaps, but to your point, I remember Stanley Lebo telling us when we were even students that or postdocs that, well, vitrification, as long as you can get the solution and get the cells to vitrify, any additional exposure is just toxic. And I didn't never took that point to heart, but that's true. So
absolutely.
Yeah, no, right. You've been talking a lot about the commercial aspect. I'm curious to know, how do you see the response of the commercial industries? Because the way we are going, we may even get rid of all the vitrification, warming, the warming media, I thought. The whole sequence will be just directly into buffers. I'm just curious
Yeah,
how the industry, the commercial industry.
They're not going to be happy, but well, at least we'll take away the misconception that ultra warm or rapid warm solutions is a thing. And people, that's the problem with the young biologist. I've been making a point with Kitazato, as I don't like the name of your solution. They're like, why? Because it has nothing to do with warming. We haven't changed warming at all. It's the post-warming events that we've changed. And so when we teach our biologists, that's an important point we need to make, that warming hasn't changed. We're still doing it fast.
Absolutely. Okay.
Yeah, I'm not concerned or sad, and I'm not saying we did 20 years something wrong. There is time needed to get to a point. It's like a fruit that is not mature at the beginning, right? But if we continue produce numbers, evidence, we get to a point where that fruit will be mature. And so this is just a very normal consequence of many years of work, what you one day figure out, we actually can do it different. It's like with cars, right? We don't need any more gas. We can use electricity. Just think about 20 years ago, somebody would say that. So, and usually the things we recognize now are not always appreciated in the moment. It takes years after that people see the benefit. That's sometimes the beauty of being an early adapter.
Yeah. Okay.
Can I have a comment?
Sure.
Mitchell mentioned the poor oocyte quality, the effect of poor oocyte quality on the results. And I'd like to also point out that, we have three different population of oocytes that needs to be vitrified. First is the patient's own oocytes, like undergoing oncological treatments or before oncological treatments. And those are usually the last resort oocytes, usually the older age, the very limited amount of oocytes that we can retrieve from the patients. The second one is the social freezing cases, and the third one is the donations. So I think we have to evaluate the results based on these three specific patient groups. So in order not to generalize the outcome for all the types of oocytes.
Well, I think ultra-fast vitrification is going to be always going to be a solution to better survival. I just don't think it's going to be the cure to bad development.
Yeah.
Because if an egg's bad, it's bad. It's not because we vitrified it fast. And I think that's what we're going to learn. That's what I've learned in a few of our test cases. And it's really depressed my embryologist because all of a sudden she's the first one to have bad outcomes. Like, what did I do wrong? I said, you didn't do anything wrong. It's the egg. So, yeah.
Yeah,
but
I
your
agree with
point's
Mick.
valid.
Yeah, I froze so many eggs, for my test results, and I didn't care about quality, right? I froze with vacuoles, I froze all kind of stuff, and with my protocol of 2 minutes, and I don't use TS, I do use DS. They all survive. I just had a case. I'm sure sometimes people don't like anecdotes, but yes, just yesterday I vitrified 43 eggs, and they were like 1 or 2 days old, and I just did it curiously for a different carrier, and 42 out of 43 survived. Even like sonar-free.
What do you mean by
TVs.
they were 1 or 2 days old?
Yeah, so
were-
eggs, they usually were immature, and we kept,
Okay.
what we do, we keep them in a basement. We don't throw them out immediately. And so that's why we were like, sometimes I cannot vitrify the same day because I just don't have time. Because we do other procedures. So, but it was interesting, and also think about, speaking with George, I'm sure, we all rely on 2 eggs at the same time. Egg freezing is not very efficient. It's time consuming, right? And if you ask embryologists, would you like to prefer freezing blastocysts or oocytes? I guarantee you 90% will say, I will have blastocysts. Because we still have a fear of freezing eggs. And we can find a protocol, I can tell you, that fear is unnecessary.
Right.
Good to know.
You know, one other point
point.
I didn't make, Fadi, is that when I looked at in the direct rehydration model, this is not a new concept either. The people in the cattle industry have been doing this for nearly a decade, where they transfer embryos directly into the uterus from ethylene glycol exposed embryos. So we know that direct rehydration can work in an in vivo model. And in our case, I was really just looking at it as a solution in the ultra-fast model because there's so little cryoprotectant to pull out. It just seems very logical. But one of my technicians, when I designed the study, one of my embryologists, when I gave her the format to study, applied it to the research discards as well, which meant just to create the embryos to study, we had to warm them up. And she applied the same treatment to the conventional vitrified embryos, and they survived. So that really is a testament to, I think, where we're going with the direct rehydration, because once we ultra fast, direct rehydration is going to be a slam dunk.
Yeah, yeah. Mitch, would you agree in saying that shorter exposure time to ES also will lead to less cryoprotectant in the oocyte or embryo that actually allows us doing the one step or even rehydration? Because I feel if we would freeze oocytes for 15 minutes ES, that rehydration directly does not work. So do we get a benefit from the short exposure time in ES that allows us the direct rehydration or the one step?
Absolutely. Yeah, yes. It's just going to be, again, not just faster and efficient from a speed standpoint, but more efficient in the exposure to less cryoprotectant and sufficient amount to bind the water molecules.
Sufficient
But
amount
then to pull them
make
out is going to be a
vitrification.
slam
Yes.
dunk.
Yeah.
Yeah.
Sounds logical. It sounds logical.
Can I ask a question, please?
Great.
Yes.
Go
ahead. Go ahead.
It's a question for both Jürgen and Mitch. Like, based on what you just said, do you think that lab outcomes and the clinical outcome will be better if we do rapid freezing, rapid warming than standard freezing, rapid warming? Is that what you are aiming in your last comment?
Well, Jorgen's data is showing to be quite good. I mean, very good. It may not, I think it will end up being as good, if not better, I think would be my answer. I don't think it's going to be worse. And there's something else I was going to say, but I'll let Jorgen reply and maybe I'll remember what I was going to say.
Yeah, for example, I did, we had eggs, we vitrified the traditional way, like the 15 minutes exposure time. And so I was trying to apply my short protocol, and I didn't get survival with DS and 1 minute DS and 1 minute wash. So I only achieved survival by going in TS first and then DS and then wash solution. So overall, I had to increase for 1 minute. Instead of 2, I can warm these oocytes, long exposure in 3 minutes, but it required a higher concentration at the beginning of TS.
So you don't recommend for us who are already have that stock of frozen eggs to try that?
I would freeze them as Mitch mentioned that before, and I think it comes from Dean Williamson. What you freeze slow, you have to thaw slow. What you freeze fast, you can warm fast.
Yeah, but that wasn't the case in the cleavage stage.
Fast warm. Huh?
Yeah, but that wasn't the case with our study in the cleavage stage embryos when we tested
I'm surprised.
frozen.
Yeah.
Yeah.
Because when I get slow frozen embryos, I thaw them slow.
Yeah, that's what we used to do, and it worked very well with the ultra rapid warming. And now we consider this as a clinical service since last May, and we are in the process of validating our clinical outcome. The other question for you, Jürgen, is about the scientific concept behind skipping the TS and warming the oocytes, ultra rapid warming of oocytes. Like, have you tried this also with the embryos, and why what came to your mind to skip the TS?
Yes, it works for, it works for, as Mitch already made, like the point from TS to direct rehydration. You can use 0.5 or even 0.25. It works with every solution. We just don't want to change too many things at the same time. So that's why we stuck with the TS. But you can go at the lower concentration, it will be fine. Or, surprisingly, no sucrose at all, right? This is, that's point number one. Other question, say, have to repeat it, please.
No,
Yeah,
my
other
question is like, when you skip the TS step in ultra-rapid warming of oocyte, what was the scientific concept behind that?
Okay, so why I use DS instead of
Yes,
TS?
direct, correct.
Yeah, so I mean, there is a nice publication also from a group from Atlanta, from RBA. They showed, what is osmolarity of these solutions. And so when you go like in ES, right, so oocyte shrink or embryo, your solutions, your osmolarity, everyone knows this, osmolarity in culture medium is about 260, 270. But if you go in ES, it goes up to like close to 2000. And when you go in VS, your osmolarity goes to 5000, right? So it's 1 point. So when we thaw, if you go in TS, so osmolarity of TS, 1 molar sucrose, is about 1300. DS had 700. So my idea is, first of all, we vitrify in VS with 0.5 molar sucrose, right? We have 15% ES, 15% DS, so 30% cryoprotectant plus 0.5 molar sucrose. And my point is, why we go in a higher sucrose as we vitrified, right? And the result is what you see and everyone is afraid of, that oocytes rising up. And what you have to do to guarantee survival, you have to bring them down, right? They come off your carrier. When you go in DS, and that is a stress for embryologists. If they don't find the eggs fast enough, they float up, they get viscosed, they look like an empty sauna. They are, for people they are not experienced, and they shouldn't do this, very hard to find. And you have only 1 minute, right? So you start like getting nervous. If you go in DS, your eggs sitting there on the carrier and not rising up, and you can pick them up. And this is a sufficient concentration. It's the same concentration we applied at vitrification. So why should we go in a higher? And when you come, what you want to do physiologically, you want to get your eggs back to the 260, 270. And if you can start with 700, you cut down that difference so significant instead of 1300, that's TS. So coming in a higher osmolarity, but getting to the physiological and shortening that time, I think is beneficial for the oocytes doing warming. That's why I did DS.
Yeah.
I just want to add the point you made about switching from conventional approach to rapid and how it affects your results. And the point I wanted to make is that, first off, we know Jorgen and I have shown we can get higher survival more consistently, and that's what we all want. We've always wanted egg freezing to be as consistent as embryo freezing, and we're going to get closer to that. We don't know for sure that it's going to improve the efficiency of development. We'll learn that over time, but we know that it's not going to be a negative. But the additive effect of having more eggs that survive and develop at the same rate, we now have a win-win. We now have more blastocysts being produced per patient. So we have increased the efficiency of the lab and its production.
One point to the speakers, including Najati. So returning back to the safety of the fast movement in the lab, not specifically to the warming, rapid warming, also sometimes early denudation, rapid denudation, and ICSI. And I want the insights from Belgium, from Europe, from Najati, and from you guys from the US.
So basically, we started the discussion.
Do we consider?
I think if we can open discussion on vitrification. So maybe one question, just to talk, I would like to ask Dr. Sujata specifically. You had a huge organization, and it's very convincing now that possibly this is the way to go. With all the data that's coming, the logic, etc. How would you want to implement this? First, would you implement it? and what is the manner in which you would go about changing the entire existing system? How long would you wait to get your data? Because that would be a message for many clinics who would want to shift over.
Okay.
So
Dr. Rajvi, like say when Organ had first published it in LinkedIn, okay, we did have a discussion at that time with Dr. Marcus, okay, and from EB. And Dr. Marcus said they are already working on it. Like I just saw the thing from the LinkedIn post, and then we discussed it there, and then he said we are trying. Then so it was more than a year ago, okay, or even before that. What we did, some of our labs where where we have very senior most embryologists, so we actually started to do some trials on donor eggs or eggs where like where patients have more eggs. So we started to do some trial, and we did find excellent survival rate, like much higher than the conventional survival rate by this ultra rapid vitrification. Then we also try, in fact, we even had one pregnancy from such ultra rapid vitrified oocyte. Now, when we tried it with blastocyst, we actually were seeing little bit of degeneration spots in the embryos. Okay. So, and then, but, so this was just a trial, this thing. So we didn't go further with it. And later on, we got to know that, like, we got to know from Birol and so many, even people from Kitazato, they themselves, they are changing the formulation. So we thought, okay, we know that this works. And now we are just actually waiting for the company to give us the SOP so we can just use that. Now, as for implementation, definitely we would implement. And then, as I said, we would start with our labs where, we have experienced embryologists. And then slowly, when we are convinced that it is like the same old protocol, then we would just take it to the other centers. And we also have a training center. So we bring our embryologists there. We can train them in these techniques. And, like we take it forward.
Fadi, I have a question to you
Exactly,
again.
Yeah.
Because
So I
before
was
we
like,
finish,
go ahead, and then I will
Yeah.
reframe my question.
Yeah.
Go ahead.
Usually when we vitrify and warm the stuff, we go for the blastocyst with highest quality. Okay. And it usually, and if you have a really poor quality embryos that have been already vitrified, and if you manage to have the pregnancy or delivery within the first couple of good quality blastocysts, the results of the poor quality blastocyst could be hindered, And my question is, because Jürgen has a big series of outcomes from the fast vitrification and warming. What could be your result, Jürgen, in terms of like a table of the poor quality embryos? Do you see any differences in survival or implantation? Of course, implantation could be different, but yeah.
So, Nikari, very simple to answer. I don't freeze poor blastocyst. You have to be very strict with what you freeze, right? If you want to do a favor to a patient and freeze something because she has something, it's maybe not the right thing. And I don't think anyone does that. But what you get out of your freezer is what you put in. So if you come with poor blastocyst, we don't freeze CC embryos. Don't expect great outcome. I don't think, without having this data, I get your point, because I was asking that multiple times, how like poor, let's call weak blastocysts will deal with that short protocol, right? I don't think they will show a difference. I don't have these numbers because I don't have these poor embryos. And I think I would encourage everyone, to look in a very strict embryo grading. Everyone can apply whatever you want, but if you are slippy on this, you might see different outcomes as we publish, right? We have to keep in mind, we warm and vitrify embryos and we see the outcome. There is a huge important step before we get these results. This is your culture system, right? We don't make this great blastocyst outcome because we freeze them fast and we thaw them fast. It is a culture system. And what's what you select finally to put in your freezer.
Okay. What I'm asking is because when people try to switch from one protocol to another, usually use like a mediocre or poor quality embryos to try, not the very best one. And if you see an unexpected outcome, maybe you are a little bit scared of changing the protocol? That's what I'm asking.
Exactly.
Yeah.
Can I add my this thing here? Because that is exactly what happened to us when we were vitrifying our blastocysts. Because since this was trial, we were not vitrifying the ones which can be transferred. We were actually vitrifying the embryos which were actually to be discarded. But surprisingly, they survived well. All of them survived well, like some 20, 25 blastocysts we had vitrified. But as I said, like we did see degeneration spots a little more. So, like actually, and that we kind of stopped it there. But definitely with poor quality blastocyst, it survives.
So, Dr.
Yeah.
Sujata, the spots could be with the quality of the blastocyst
Yes, that's what
itself,
I'm saying.
nothing to
That's
do
what I'm
with-
Yeah.
saying. But then, like, see, our embryologists are always comparing between, you have a visual perception, right? Like you are freezing good quality embryos and you get good quality embryos back after warming. But then here you see the spots, but the starting material itself was not, good blastocysts.
Yeah,
Dr.
there's a good
Sujata,
study.
sorry.
There's a good study from Belgium that showed that only 30% of your blastocysts you fall have no degenerate cells. 50% of the blastocysts have about 0 to 10 cells. They are dead. So this is a very normal occurrence and it shouldn't be of concern. I don't think every one of us has ability to see these dead cells.
Yeah.
If you see them, then the numbers may be obviously larger and there is something wrong. But looking at a blastocyst with 120, 130 cells, and then finding that 10 they are dead, I tell you after like 30 years of IVF, I'm impossible to do this.
One question, Dr. Sujata. Since you tested this protocol on the blastocysts that were to be discarded, but you vitrified and warmed them, by any chance, did you transfer any of those?
No,
After?
no,
Yeah.
no.
Dr. Bindu, I can answer this question because I have a first-hand experience with this. There are certain circumstances when we have only a few blastocysts, maybe one or two, which are CC grade or BC grade. So respecting the patient's decision, we have to freeze them and we have to transfer them also because we don't have any choice. So of course, I cannot expect the same results as I'm freezing AA embryos or AB embryos. So yeah, we have certain transfers when we transfer poor quality blastocysts. The survival was as I was expecting, but then the results were, yes, compromised.
I saw a
Yes,
question
just
on day
as
7
day 6
blastocysts.
blastocysts, preferably, we do not. Given a chance, we'll choose a day 5 blastocyst, but even a day 6 blastocyst available will transfer. Similarly, CC grade blastocyst also, if there are no other available for the patient, we might freeze, vitrify, and then transfer as well. And the pregnancy rates may not be at par, obviously, with the good ones. But then, yes, we have instances where about 10 to 15%, we do get results, positive results out of those as well.
Yeah, I think, everyone is maybe freezing mediocre blastocysts to some extent. But the point is we have very few data overall because most patients have good embryos and we use them in the first attempt or in the second attempt. And then, they get pregnant, they deliver, and then we sit on these blastocysts, they have less grade, and so they will never be used, right? In most situations.
So
I think we have come to the end. Is it almost? Can I want to ask a question to Jorgen.
Yeah, go ahead.
He did mention about assisted hatching or collapsing the blastocyst. I didn't get it. Like, what were you saying earlier? Is it important?
So, I saw, you remember my slide when I did my pre-validation for before in the clinical setting, like over 600 blastocysts. And, I used this material. You used like poor ones out of your culture, or you used embryos a patient didn't sign for cryo, right? Before you threw them out. So we had a lot of embryos. My lab is now since 2004, and we have a lot of embryos over time accumulated. And so patients are now signing for disposition, right? So, and they can choose between research, simple disposition, or stem cell research. And when we do for research, we can use them in-house for training of embryologists or for something like this. So before I throw them out, I use them for thawing, and I did my 24-hour culture. But I split the PGD embryos in the non-PGD embryos, and I had after 24 hours a significant higher totally hatching rate in the PGD embryos. And it makes sense, right? We make an opening and the embryo will choose this. In the non-biopsied embryos, instead of 78%, I only had 67%. So more than 20% less of these embryos were able to hatch out. And that's what I'm saying is where I would apply assisting hatching after warming to give them another chance to hatch out. All our blastocysts usually, if they are not PGD embryos, and that's less and less, they get collapsed before we freeze, right?
Okay.
But PGD embryos, we don't make an opening, day 3, day 4, we don't do this. Right at the biopsy, and when we biopsy, and 5 minutes later, embryo is frozen. We don't put them back in culture. We don't give them, for whatever reason, a chance to re-expand and waste energy. So we preserve its energy at the time when we warm this embryo, right? So these embryos don't need assisted collapsing, but we also have cycles still, maybe 30%, they don't do genetic testing, where we freeze embryos, not biopsied, and we apply collapsing, assisted collapsing.
Okay.
Dr.
Very
Jorgen,
simple,
coming
right?
back
One
to
shot.
your, yeah, to
Please
your,
go.
the PGT, it's been, when you show that the PGT biopsied embryos had better results, and you think it's the whole. But the fact is, once you've done a biopsy, you would have transferred euploid embryos. So is it to do with the biopsy, or is it just because you must have transferred euploid embryos in this case that you had a better pregnancy rate or better results?
Oh, you mean, yeah, so we get good results with both group, but applying a euploid embryo.
Yeah. So it
I'm
could
sorry.
just be because, the question is that you have a PGT group and a biopsied group and a non-biopsied group, and
Correct.
the result in the biopsied is better, right?
In terms of hatching, right? Not outcome.
Yes.
They were
Okay.
just, that was our initial study. It was just our initial study. These embryos were for disposition. We just cultured them for 24
Not
hours
outcome.
and then were discarded. They were not transferred.
Okay, fine. I think we had
Mitchell
Dr.
has a
Fadi.
point. Yeah, Mitchell has a point first.
Yes.
Our guest.
I just want, well, on that last point, I agree with Jorgen's issues, but what we learned from collapsing too depended on the cryoprotectant. So when you're using DMSO and ethylene glycol, it equilibrated so quickly that you needed to collapse them. Because when we use glycerol, we didn't need to collapse them because glycerol was slower permeating and it collapsed the embryo itself. So you want to get less water. You want to get that water out of the blastocele cavity. That's important. But I think with ultra fast, I mean, we haven't really looked at that point. It may not be a factor at all because we're quickly dehydrating. I did want to answer a couple points though that were in the chat, and that is based on quality. I think you got to start somewhere, and a lot of our research does include C quality embryos, and we do still get good survival. But we can't expect a C quality ICM to actually make a baby very efficiently. And the C quality trophectoderms are going to be challenged because they have to attack the uterus and implant, and they're going to be compromised. But I think the embryo quality is not going to be impacted by our technology. Again, the egg quality is a different story. We may see some reductions. But also somebody asked about day 7 embryos. I think day 7 embryos, to Dr. Sukla's point, we have patients who have only maybe no embryos on day 6. So we go day 7 and we have all of a sudden a day 7 embryo. And those day 7 embryos can make babies, but less efficiently. So we just have to keep it all in perspective when we're working with these embryos.
Dr. Fadi, we had a whole lot of questions on various aspects beyond vitrification, but the discussion was going so well, so we have not got into that, Alia. So maybe we may need to have another discussion just to discuss the other aspects where we have things.
Yeah, sure. But it was amazing. Thank you all. Thank you all for your sharing. Thank you all for the knowledge. Thank you all for the time.
Maybe somebody would like to summarize when people want to shift, how should they go about it? Maybe start with the poor quality blastocysts just to see that they survive. They'll not lead to pregnancies. They may not be transferred. So you get confidence. As far as skill is concerned, it's possibly easier than conventional vitrification. So there's not much of relatively less skill involved because the embryos just go down. And as Dr. Jürgen said, people as embryologists are happy. But maybe at some point one would need to put in guidelines of how to shift over, because it's like when you add another culture medium, you want to compare both and, gradually shift over. One is not going to stop conventional vitrification and move to this. So what should be the process? And maybe at some point of time, one will need some guidance for people wanting to go to this, but, will not to drive. So
I always would recommend in-house validation for everyone, right?
Yeah.
I never accepted a paper and just implement it. Even it's from Mitch, right? What I really honor very much. But, our work as a lab director is listening, be open, but testing. Everyone is here for many years. How many anecdotes in our life we had to accept, right? Mm-hmm. And if you follow this, on the end, you don't know what direction you should go. So you have to do your homework. We all have a PhD. We still have to that science, that curiosity in us, and we have to use it every day. But we have to use it because, there's a nice saying, people who are looking in the past or in the present will never see the future, right? So we have to be open for the future.
Conclusion.
Thank you.
Yeah.
Thank you to all the moderators and panelists and everyone. I request Dr. Fadi and Dr. Sanjay Shukla, sir, please, if you could give the vote of thanks, both of you, sir. Dr. Fadi,
we appreciate the speakers, the moderators, the panelists, and the audience for staying long time. Maybe now in India it's night, so and it's a beginning for the US. Look, so it's still early. We appreciate your presence, and hopefully we look forward for and waiting for further research regarding your findings, and looking forward also for further joint activities with iHERA. Thank you. Sanjay?
Perfect. So not expecting a better opening like this. It was certainly a very enriching and very, thought-provoking discussion, and listening to all the greats like Yogan, Mitch, and Nichati. We look forward to have more collaboration with the MEFS, and maybe sometimes I think I'm longing to meet Jorgen in person for a long time. Hope to see you soon. Wish you all a good day, good evening, and good night.
Thank you.
Thank you very much,
everyone.
Thank you.
Can I ask, request Shivam that all the people can come in one screen and we can have a group photograph for all of us today here? It will be a wonderful opportunity. Hassan, can you just come near your camera, sir? Sanjay, sir, you also. Please come forward towards the camera.
I'm bringing the camera towards me.
Shivam, can everybody come in one frame? If you can pin all of us together, we all be visible together.
Maybe you have to do yourself for your screen.
Faster and fastest is fine, but let it not be fast and furious.
We can stop the recording if possible.
Yeah.
Thank you so much to all our delegates who have joined us today, and to all our esteemed faculties here today. And have a good night and have a wonderful day ahead.
Yeah.
Thank you very much.
Recording stop.